Recording in progress.
To everyone. Good morning, everyone. Welcome to the meeting. Hopefully, some of you were able to see the sessions that happened yesterday. We had a superb day one session. My name is Dr. Sadaf Mimon. I'm a pathologist from Mackenzie Health, Richmond Hill, Ontario, Canada. I'm the lead pathologist in hematopathology and transfusion medicine. I also serve as the chair of the general pathology section at the Canadian Association of Pathology, and I'm also the clinical assistant professor at the McMaster University in Ontario, Canada. So I would like to welcome everyone over here to the Digital Pathology NEI UCGCongress that is happening in Berlin, Germany. I'm actually currently right now in Berlin and enjoyed my day one over here in person. The global gathering of pathology experts in digital pathology. The Tuesday sessions were very, very interactive and very informative, and we learned a lot. So let's begin our day two today. It's going to be quite, it's very heavy with a lot of great speakers all around the world.
I cannot hear.
Is this Dr. Vivek Anand? Everyone is able to hear me, Dr. Anand? Amal, Hassan, everybody, if you can check in the chat box. I think you just have to check your audio setting. Even the organizers are able to hear me. I think our first speaker, Dr. Vivek Anand, Ashriji from India. He is from Shanta Shripat Reggie, Mumbai, India. The title of his talk is Turning Your Brain in Digital Pathology, a very exciting one, arriving in the future today. So Dr. Anand, why don't you start your presentation? Recording in progress. Dr. Anand is our first speaker. Dr. Anand, can you hear us?
Yes, now I
Okay.
can hear you.
Oh, sure. Please go ahead and start your talk. So the title of your talk
There
I've
is
already.
there is some disturbing noise in the background.
I think someone has logged the call. Everyone, please mute your microphone. All of the attendees, kindly mute.
Dr. Vivekanand, could you please mute your laptop or mobile mic because you have opened both mics for laptop as well as mobile. That's why the disturbance is there.
You can start your talk.
You please speak from your phone because your audio is not there. We cannot hear you, Dr. Vivekanand.
Can you hear me now? Can all of you hear me now?
Please join with one system only, either phone or system. Because of that, echo is there.
Am I audible now? My phone is muted. My phone is muted. May I speak now?
With the interest of time, we will introduce our next speaker. We will request Dr. Vivekanand to log out and log in again. Organizers, can you please call Dr. Anand and convey this message so we can start the next session? And in the meanwhile, we can figure out how best we could help Dr. Anand. So Dr. Anand will just be able to either log in through computer or through your phone. So ideally, if you're using your computer, because you'll be sharing your talk, so it's better if you can just log in with your computer. You can switch off your phone. We can give it one more try. Is our next speaker over here? Dr. Kareen Michael Tabarani.
Hello.
Good morning. So my next speaker is Dr. Kareen Michelle Tabarani. Did I get it right?
Kareen Michelle Tabarani, yes.
So welcome, Dr. Tabarani. So Dr. Tabarani is the of oral medicine AOMs, and the title of her talk is bisphosphonate-induced osteochemonecrosis of the jaw in oral surgery. Dr. Kareen is from Russia. So I'm passing her the stage to deliver her speech. Thank you. The floor is yours.
Yes, hello everyone. Let me share the screen first. You can see the screen, huh, doctor? Are you able to see it?
Yes.
Hello everyone. It's a pleasure to be with you today in the 10th World Digital Congress, Pathology, where I will be discussing one of my favorite topics and the most famous topic in oral surgery and oral medicine, which is the osteochemonecrosis of the jaw induced by the bisphosphonate. So today, the prevention and the treatment are no more a medical enigma. First, greeting from Abu Dhabi, the capital of the United Arab Emirates. Since years, I was lecturing around, trying to spread awareness on a very delicate subject of the ONJ, osteochemonecrosis of the jaw. I lectured in the Middle East, in Europe. I also lectured alongside Professor Marks in the BioCRA-CISBO meeting in 2011, where we discussed the latest recommendation for treatment and prevention of osteochemonecrosis of the jaw. Sorry. So let's start with a brief introduction. So the bisphosphonates are synthetic compound with chemical structure similar to that of inorganic pyrophosphate. It is used in order to treat many bone pathologies like osteoporosis, Paget disease. But like any other chemical structure, it has its advantages, but it also has a very, very, very serious complication, which is the osteochemonecrosis of the jaw. We can distinguish 3 generations. The first generation is the non-amino bisphosphonate. The 2 remaining generations are amino bisphosphonate. We're going to see the differences. So the first publication was issued by Marks in 2003, and since then the number of cases are growing epidemic. So the objectives today is to depict the importance of bisphosphonate in treating many bone pathologies, assess and review the available data on the prevention and treatment of bisphosphonate-induced osteochemonecrosis of the jaw, analyze the concept of the pathological phenomena, and propose some new recommendation established by the Italian Society for the Study of Bisphosphonate in Oral Surgery, the CISBO. Also address recent work on the fibrin-based biomaterial and the fibrin, platelet-rich fibrin. So bisphosphonates are stable analog of inorganic pyrophosphate characterized by phosphate carbon phosphate structure. So we have 2 routes of administration. We have the intravenous bisphosphonate that is used for multiple myeloma related skeletal complication, hypercalcemia of malignancy, whether the oral bisphosphonate are, as I can say, lighter pathologies like osteoporosis, Paget disease, and osteogenesis imperfecta. So the first generation is the etidronate, clodronate. This is the specially used bisphosphonate. And the 2 remaining are pamidronate, alendronate, second generation, third generation, risedronate, ibandronate, and zoledronate. So the prescription of bisphosphonate is increasing since years. Why? Because of its biological effect, an inhibition of soft tissue calcification, inhibition of bone resorption, and therefore reduction in bone remodeling, anti-tumor effect, anti-angiogenic effect, especially the zoledronic acid. So this is the remodeling cycle. So what's the difference in the action? So if we're talking about non-amino bisphosphonate, we're talking about clodronate. So it will be acting on the necrosis of the osteoid. Whether the amino bisphosphonate, which is the second and the third generation, will be acting on the mevalonate pathway. So it will inhibit the protein prenylization, will be having inhibition of the farnesyl pyrophosphate synthetase, and therefore will be having apoptosis of the osteoclasts. So it's a different mechanism of action. So this is how it works. It inhibits the farnesyl pyrophosphate synthetase, and therefore will be having apoptosis of the osteoclast. So what are the strengths? So if we're going from the first generation, from the etidronate to the clodronate, we're talking 1 to 10. If we're going to the second to the third generation, so pamidronate, alendronate, we're talking second generation, 100 to 1,000. Third generation, we're talking risedronate, ibandronate, zoledronate. It goes from 3,000 to 10,000. As per Marx in 2005, he claimed that the higher the potency and the longer the duration of these medicine, the more there is a risk of ONJ, of osteonecrosis of the jaw. So what is osteochemonecrosis of the jaw? So it's related to the intake of bisphosphonate. It's an exposed non-healed bone in the maxilla or the mandible, extending for more than 8 weeks. So the patient is taking bisphosphonate with no radiation therapy, and he has an exposed bone, whether maxilla or mandible. We're going to see the stages. So if it's the stage 1, it's an asymptomatic exposure. It can be also associated to bone loss, spontaneous bone loss. So it's unhealed for 8 weeks. Stage 2, we have an infection. We're starting to have pain in the area. And stage 3, this is the complicated case. We have fistula, we have fractures. But today we're talking about stage 0. So if the osteonecrosis of the jaw is defined as being exposed bone for more than 8 weeks, what about stage 0? As you can see here, we have a sequestrum, but the evolution of the bone is different than the evolution of the mucosa. So we have a mucosa that is covering the sequestrum in a patient taking bisphosphonate. So maybe we should relook into the definition of the osteonecrosis of the jaw. So what are the signs? We have a spontaneous necrosis associated to periodontal involvement. We have spontaneous, here we cannot see. We have a spontaneous stomatomucositis in the area, as you can see the red areas, and it's starting to have a bone exposure. We have mucosal ulceration and bone exposure for more than 8 weeks, as you can see on the mandibular exostosis. So the prevalence factor, as per Marx in 2005, can be divided into medical and dental. So the medical, we have a malignant tumor. We have associated factor like the dexamethasone. He's taking dexamethasone. Of course, the dose and the duration will affect. We have a tobacco, age, alcohol. The dental part is periodontitis, so it's an infection site. We have caries, dental abscesses, failure of odontic treatment, mandibular exostosis, but the major risk factor are age, obesity, and tobacco. So what are the symptoms? So mainly it's asymptomatic in 31% of the cases. Sometimes it's a painful bone exposure. We have edema, we have infection, we have a cutaneous and mucosal fistula, and rare paresthesia. When we're talking paresthesia, we're talking more into the third stage. So we have involvement of the lower alveolar nerve. We're going to see some cases. So who are the healthcare professionals that are involved today? It's not only us, the maxillofacial surgeon, it's also the oncologist, the hematologist, rheumatologist, endocrinologist, orthopedics, especially internist, and the GP dentist who will be the first to depict these cases. So this is how the complication can go. It can be a tear infection, it can be a fracture, a fistula in the area. So we have an aggressive evolution. We might have a sequestrum. We can have a cutaneous fistula, pathological fracture. And as I said, sometimes there's no concordance between the mucosal evolution and the bone evolution. So what are the ethiopathologies? We have many hypotheses and theories. Let's start with the hypocellularity and the hypovascularization theories, which can be linked a little bit to the osteoradionecrosis. We have an infectious hypothesis, cytotoxic hypothesis, and we have the enhancement of mineralization theory. So let's look a little bit histopathologically. So if you can see the osteoradionecrosis, you can see a homogeneous necrosis. Whether if you look into the osteochemonecrosis, we have multiple necrotic area present in a vital surrounding bone. So there's a little bit of a difference in the definition also between the osteochemonecrosis and the osteoradionecrosis. So I will show you this clinical case for my colleague, and they placed an implant. You know, 17 years ago, the osteochemonecrosis was not very clear as a definition. So he placed an implant and he placed a crown over it. After 6 months, the patient came with a peri-implantitis. So it's an infection around an implant. And they diagnosed it as peri-implantitis. The problem is they weren't aware that the bisphosphonate might cause osteochemonecrosis. So they tried to treat it first conservatively in a not traumatic way. It did not work. So they had to go to the guided bone regeneration, and having an invasive treatment on a, as we can say, a dead bone, there will not be any remodeling. So they had to lose the implant, as you can see here, the sequestrum, and the healing process was devastating in this case. So the number of osteonecrosis of the jaw is increasing since years. And the evolution sometimes is unpredictable. This is why I published with my colleagues, Raffaele Volpi and Fawzi Riashi, in the International Dentistry Journal about the clinical radiological evolution and the prognosis. As you can see here, how it's presented. We have an occlusal view. You can see the osteolysis extending buccal and lingual, and it involves the lower alveolar nerve. It extends to the basal area, so there's a high risk of fracture of the jaw. As you can see here, this is the panoramic view. You can see the disruption of the inferior border extending to the mandibular angle. And this is the intraoral presentation. So what about having bad prognosis? What is bad prognosis for us as surgeons? So when we see a patient having an intravenous bisphosphonate, when we see him having a C-terminal telopeptide. So we know that the C-terminal telopeptide, which is CTX test, it's a biological marker of the bone remodeling, and it assesses the osteoclastic activity and the resorption. So having it less than 150 with the latest publication, it says that it's a bad remodeling. So we have a risk of osteonecrosis of the jaw. Whether a good prognosis is having it more than 150. In the mandible, there's less vascularization, so high risk of osteonecrosis, cancer patient, comorbidity factor, the dexamethasone and chemotherapy, and of course, stage 2 and 3, and having an aggressive surgical intervention. So what should we do today in order to prevent this osteonecrosis of the jaw? Always, we need to have a collaboration with all our team of doctors. We need to remove all the local risk factor and the general risk factor. We need to start removing the infection, enhance the oral health, and all the all the teeth that we cannot conserve, we need to remove prior to starting the bisphosphonate treatment. Marx in 2000. 2007. So he said that all the patients that are diagnosed by osteoporosis and are prescribed bisphosphonate or non-restorable teeth should be removed. And patient taking oral bisphosphonate and for less than 3 years, CTX testing is not necessary. There is no risk of osteonecrosis. You can conduct your surgery without any complication. Whether if it's more than 3 years, CTX is a must, and it should be related to some drug holidays, of course, with the collaboration of the physician, and it depends why the patient is taking the bisphosphonate. So we need to inform the patient prior to starting the bisphosphonate. We need to regular follow-up 3 months for intravenous bisphosphonate, 6 months for oral bisphosphonate. The objective is always to minimize risk of development of osteonecrosis of the jaw. So the ADA in 2006 said that there is always a must to treat all the teeth prior to starting the bisphosphonate. So in case we need to do an invasive surgery and we cannot postpone it, we need to do each sextant apart. So don't go for the 4 sextant together. And we leave 2 months between each sextant with a chlorhexidine mouthwash 0.12 each period of time. Of course, Fidel, I call Dr. Fidel the objective because he's always objecting. So he finds that all these recommendations by the ADA and by Marks are not supported by any evidence, and further investigation should be conducted. So what about extraction in case of bisphosphonate, IV bisphosphonate? So we need to start 3 days before surgical intervention, 1 gram of amoxicillin each 8 hours, and continue 17 days. A traumatic extraction should be done. All the traumatic extraction should be postponed. Mucosal periosteal tensionless flap, chlorhexidine 0.2, 3 times per day for 17 days. So he had, this is for Lodi and Georgia, they had ONJ at 3 months in 4 locations, at 6 months in 1 location out of 185 extractions. What about doing implant in the case of bisphosphonate? So we have 2 risks. Either we have implant failure or osteonecrosis or both synergistically at the same time. This is the American Dental Association expert panel. So for the oral bisphosphonate, less than 3 years treatment, should we place an implant? As per my experience, yes, especially that I follow the CISPO recommendation that we're going to see in a while. More than 3 years, stop bisphosphonate 3 to 6 months before implant placement. Of course, always in collaboration with the physician who's treating the patient, and why the patient is taking bisphosphonate, because we don't want to compromise his general health. Antibiotics, closure by first intention, treatment per quadrant. What about the IV bisphosphonate? So as per the IV bisphosphonate, it's an absolute contraindication for implant placement and bone graft. So there's few cases as per Grant, Bells, Goss, Jeffcoat, and Fugazotto, where they said that in case there's a short exposure, like 4 doses prior to implant placement, there is no problem. Follow-up after 4 months is also a must. I will show you this case by Lazarovici, where he had a 6-year-old man, 17 months after placing the implant, IV zoledronic acid treatment for multiple myeloma. You can see there's an exposed bone, and he lost his implant. You can see the necrotic bone integrating to the implant. This is a case that we had in our facility. So this is a patient that had 10 years before she placed an implant. And after 5 years of placing the implant and loading the implant, she started the zoledronic acid. 1 year afterwards, she came with mobility of this tooth since she had a generalized periodontitis. So this tooth was lost, and the evolution was devastating. First, she was diagnosed for peri-implantitis because she did not mention to us starting any bisphosphonate treatment. So we did it very conservatively. We were lucky because if we did an advanced intervention, it would have been very bad consequences. So we did very conservatively, but it did not. We followed her each 2 weeks. So the symptoms were stopped for 1 month. Follow up, we had an advanced bone loss in the area, as you can see here. So I had to cut the bridge and remove it. Give the CISPO recommendation that we're going to see, and now the situation is stable, but we still have an unrestored area where the patient cannot eat, so we had to place a RPD lower. Madrid also, he said that in case of cancerous patient taking IV, do not go for any further surgical treatment. So what about periodontal lesion and bisphosphonate? So as per Edward in 2008, there is a risk factor of osteonecrosis of the jaw. So periodontal disease, the treatment should be non-surgical because there is absence of healing, and the GBR bone graft should not be conducted in these cases, and tensionless atraumatic closure following the surgery should be done. Now, I'm going to share my experience, my small experience on this biological fibrin glue that I use in France with my colleagues. So the good part about this case of using the fibrin glue is it allows diffusion of proteins, and it provides of wound healing. So I published with my colleagues, Fawzi Riashi and Sophie Lejeune in Pontchaillou Hospital about this technique. So it's transformed to insoluble fibrin influenced by the action of thrombin and factor. Most of the factor, we have thrombin, fibrin, and factor. And we have another factor that it prevents the fibrinolysis that induce a plasmatic protease for a period of up to 15 days. This is what I need you to know, that isolating the area of surgery, it will give time for the healing. And especially when you have a patient that is taking bisphosphonate and having risk of infection, this will give time for it to heal. So this is a simple case of extraction, and this is how we apply it. We just place a hemosponge and we cover it by the fibrin glue. Another clinical case where I had to do an extraction and enucleate the cyst in a patient taking Zometa, 4 milligrams per month. As you can see, this is the extraction. It wasn't really aggressive. We removed the lesion and we placed the fibrin glue on the area. As you can see, we had a total healing. And this is 3 months after enucleation, no sign of osteonecrosis of the jaw. Of course, the bone healing needs time. So how do we manage the case of ONJ? As per Marks in 2007, he said that if there's no pain in the area, so it's a stage 1, having chlorhexidine 0.12 is enough. Whether if we start having pain, it means we jump to the stage 2. So we have an infection, a penicillin VK 500 4 times daily for 14 days until the pain is controlled. And having a debridement or an aggressive surgery will only lead to more exposed bone in the area. So there are 2 treatment modalities. They work synergistically, but sometimes stopping at the medical treatment can be enough without jumping to the surgical treatment if we are lucky. So we have the medical treatment. We're going to see what molecule we're using. And we have surgical treatment that should be always atraumatic with soft tissue stabilization using resorbable stitches. What about PRF? There's a lot of people before starting this lecture, they sent me via LinkedIn asking me, can you discuss the PRF? Of course, I use PRF in certain cases, for aggressive cases. So I will share with you the literature for Miranda in 2021, which was one of the latest one. We have on 37 patients that had extraction with PRF placement, maxilla and mandible. She found 3 patients with oral bisphosphonate exposure and 2 patients of bone exposure in IV bisphosphonate following extractions. So the PRF, as per Sue also in 2020, the PRF in conjunction with the extraction, it will enhance the healing, but it will not prevent the osteonecrosis of the jaw. Of course, it's a stem cells, like this is how we use it here. I'm using it also for bone regeneration. It will enhance the healing in many cases, but it will not prevent osteonecrosis of the jaw. So the main, it's an autologous platelet concentrate that consists of leukocyte platelets and cytokine and stem cells. It's considered effective in bone regeneration and will improve the osteogenesis ability of other materials, but will not prevent osteonecrosis of the jaw. Now, the last part of my lecture today, which is the main part, are the CISBO recommendation, the Italian Society for the Study of Bisphosphonate recommendation that we use for prevention and treatment of osteonecrosis of the jaw that we published in the International Journal with my colleagues Raffaele Volpi and Fabrizio Rossi, the Australian edition in 2015. So the prevention is we give antibiotics, 2 grams of amoxicillin associated to metronidazole 500, 1 gram per day 4 days before the intervention, and 10 days post-operatively. We give also bicarbonate mouthwash for 1 month. I start 1 week before and I continue further because the acidity, we're going to see the latest publication. Control each 15 days for 2 months with normal saline irrigation of the wound. Resolvable stitches, 910, can be used to stabilize soft tissue. Tocopherol vitamin E with cholecalciferol vitamin D. Local vitamin E and chlorhexidine gel for 1 month. Interruption of any risk factors. And with the collaboration of the physician, we will replace the aminobisphosphonate with non-amino bisphosphonate like clodronate. So this is a clinical case where we had to do a simple extraction, and that in the patient taking didronel and aradia, we had no osteonecrosis. Another clinical case for my colleagues in CISBO, we placed an implant in a patient taking zomida, bondronate, and or aradia. We placed here inositide biomed 3i. We had no sign of osteonecrosis of the jaw. Another clinical case, we had to do a clearance for the teeth. And as you can see, we had a total healing. So there is no risk of osteonecrosis of the jaw in this case. So what about the treatment of necrosis of the jaw? So this is in our latest also publication. So the clinical case when we have a stage 1, so we don't have an infection yet. We have bone exposure and asymptomatic bone. We go for chlorhexidine 0.2. We control each 15 to 20 days. And should we continue the bisphosphonate dependent on the case? Stage 2, we will start antibiotic for a simple reason that this is an infection. Stage 2 is where the pain starts. So we will give antibiotic, not always 2 to 3 months. Sometimes it's limited to 3 weeks, dependent on the evolution of osteonecrosis of the jaw. 15 days chlorhexidine 0.2%, control of pain, atraumatic bone curettage, and irrigation. Stage 3 is the same as stage 1. We will add PTH and PRF, and we need to do culture. We need to see what's the bacteria in the area. So this is a clinical case that came to me. It was referred by a colleague. You can see the exposed bone. There was pain, and she was taking Zometa for breast cancer. And after only 6 months, she had lost her teeth. Of course, she has generalized periodontitis, which is a risk factor. So she lost her molar, and this molar was painful, and it was moving. And the bottom one also, it was painful. This is the upper part, the upper maxilla. You can see the exposed bone. So I had to remove this tooth who had the mobility. And you can see there's not much bleeding like that we experience when you have a normal surgery, limited bleeding. So this is I had to treat her with a CISPO recommendation. This is the sequestrum that I had with the tooth. And you can see here we had the healing. Whether for the bottom one, the lower maxilla, we had this exposure. You can see how the bone is exposed. She lost her tooth. And you can see the extension of the sequestrum to the lower alveolar nerve. So it's a very big sequestrum that we removed atraumatically after medical treatment for a certain period of time. And you can see what we had at the end. So the idea here was to enhance the quality of life of the patient. I know it will be hard for her to consume food in a proper way, but it's better than to have pain and infection and exposed bone in the area. We stabilized the ONJ. So stage 1, we have to interrupt the bisphosphonate in collaboration with the physician or switch it to clodronate, and chlorhexidine 0.2, control each 15 to 20 days with a good oral hygiene. What about the stage 2? So we said that we need to switch the amino bisphosphonate with non-amino bisphosphonate. So what we're recommending is the usage of clodronate because it inhibits bone resorption and it has an anti-inflammatory activity. So it's inhibiting the liberation of cytokine in the area. Antibiotic amoxicillin 2 gram associated to metronidazole for 2 to 3 months. As per Hofer in 2011, there's a higher success rate after prolonged preoperative antibiotic therapy that might be linked to an infection role of ONJ etiology requiring adequate treatment. Stage 2 also will give amphotericin B fungizone 80 milligram daily, chlorhexidine 0.12, minor analgesic in case of severe pain, and enoxaparin Lovenox. Why should we give bicarbonate mouthwash? So the present perspective reflects an existing theory and introduce the hypothesis that local tissue acidosis, so there is an acidosis in the jawbone, offers a conclusive pathology model and can be the missing link in the osteonecrosis of the jaw, as per Otto in 2010. Cholecalciferol, vitamin D, and monadiol vitamin K with pontoxifilin and tocopherol So as per Epstein in 2010, there was 74% decrease in area of bone exposure and symptoms control was achieved. PTH 134, 400 UE. So as per Bashtisky, their therapy as compared with placebo was associated with improvement of clinical outcomes. So it might offer a therapeutic potential for localized bone defects of the jaw. What about replacement of amino bisphosphonate with non-amino bisphosphonate like rodronate, since it has an anti-inflammatory activity? So for Uwazimi in 2009, he saw that it will inhibit the incorporation of the amino bisphosphonate into cells related to inflammation and necrosis. So the clodronate could be used as a combination drug with the amino bisphosphonates, because we know that the risk of osteonecrosis in the amino bisphosphonate state, the generation, second generation and third generation is higher than in the clodronate, which is mostly absent. So it prevents the necrotic action while retaining their anti-resorptive effect. So the clodronate could be useful as substitution drug or in concordance with the amino bisphosphonate. My colleagues in the CISBO, Raffaele Volpi, Rossi, and Trizi, they said there's a reversible activity. So we have an apoptotic osteoclast, anti-pain, antioxidant action. It has an intrinsic action which stimulates the differentiation and activity of osteoblasts and their anti-inflammatory activity. So the potential use of this clodronate first generation bisphosphonate as a topical treatment to contract the osteolytic process in the peri-implant tissue, it will promote, they found, neoformation of bone around the implants. So this is a clinical case for the CISBO. It was a stage 1. So after using the CISBO recommendation, we had a total healing. Another case, we have an exposed bone. You can see the sequestrum in the area. After CISBO recommendation also, we picked up the sequestrum and we had an underneath healing. Another case that came to me taking Von Viva 3 milligrams in 3 years. She had, this is the preoperative, she had an extraction. And the problem is they came to me like this. You see the exposed bone, there was pus. So it was stage 2. Also, they did a stitch using silk. So as you can see here. So I was curious to do the CTX. And I started the Ciprobay, the quinolone. So as you can see here, you can see the underneath healing, even though we had a good bone loss in the area. Stage 3 are the same as stage 2, but we do a culture of the bacteria, so we need to know. So I will close with this case of a 70-year-old male taking Zometa since 5 milligrams since only 6 months. So they called me from Hotel Dieu de France with Dr. Slailati, and they told me, Karine, we have a case. It's a very aggressive evolution of osteonecrosis of the jaw. He lost all his teeth. So in only 6 months, he had lower teeth. Of course, he had the periodontitis. So he lost all his teeth spontaneously only in 6 months. And he evolved from this panoramic to this panoramic in only 6 months. You can see the big sequestrum. You can see the fracture in the lower jaw. So intraorally, this was the case. There was halitosis. He was under antibiotics, so it was becoming asymptomatic for a certain period of time. And extra orally, you can see the fistula in the area. So what should we do in this case? It was a traumatic intervention. So we removed the sequestrum. As you can see, it's almost half of the mandible. And we dissected the fistula and we placed a drain, and we closed with a fibrin glue and resorbable stitches. So after 3 months, this is the situation. We had a healing. We did not go for osteosynthetic plaques or titanium screws because it's an aggressive treatment. And this will be planned later on. We will see how the evolution will go. So today, the CTX is C-terminal telopeptide, which is a biological marker of bone remodeling, and it assesses, as I said, the osteoclastic activity and the resorption. When we have an increased CTX, the question to be asked, does it mean an increase of the osteochemonecrosis of the jaw evolution, or does it mean a good prognosis? So this is a question to be asked. So today, the importance is what molecule our patient is taking. So zalidronate, alendronate, pamidronate, which generation? The route of administration, is it IV or is it oral? The dosage, how much he's taking, the length of treatment, the associated factor, and the most important thing is the informed consent. We need to inform the patient what we're going to do. So always preventive approach, patient information, communication with our colleagues, oncologists and hematologists, oral health maintenance prior to treatment with bisphosphonate, regular checkup each 3 to 6 months, and low risk if we have oral bisphosphonate compared to IV bisphosphonate. So in conclusion, a clear understanding of bone metabolism, endoceous implant integration, wound healing, and bisphosphonate pharmacology is needed to make an educated treatment decision. Of course, additional research is required to determine if additional diagnostic testing or treatment modification are actually necessary, especially in case of CTX increase. And I will close with this quote for Nicholson, where he said that rather than regarding such activities as irrelevant distraction, we must realize that informing the public is a vital aspect of our job. And I'd like to thank you for your attention and invite you to join us in the Vancouver in the ICOMS 2023 that will be held in Canada in June, where I'll be lecturing on the clinical and radiological assessment of evolution and prognosis of the osteonecrosis of the jaw. I would like to share my personal email for any further question. I'd like to thank you for your attention.
Thank you so much, Dr. Karine Michelle Chabarani. So this was our speaker from UAE. The wonderful talk. Any questions for Dr. Chabarani? Great, thank you. Thank you, Dr. Chabarani, for your time. Nice meeting you. Okay, so I'll move on to our next speaker. So Dr. Vivek Anand from India, our keynote speaker, churning your brain in digital pathology, arriving in the future today. So hopefully we'll be able to hear Dr. Vivek Anand. You are on mute, Dr. Vivek Anand. I'm still not able to hear you. Dr. Vivek Anand, we cannot hear you, unfortunately. There's a problem connecting your audio. It seems like the issue with the audio is not yet resolved. Dr. Vivek Anand, we are not able to hear you. So with the interest of time, I'm going to introduce my next speaker. Our next speaker is actually the speaker from yesterday. Mr. Elton Rixapa, Mr. Troy Bankhead from Luxembourg, and he will deliver his speech on the impact of artificial intelligence in the clinical pathology arena, making waves in liquid-based media. Okay. Mr. Bankhead, take it from there.
Thank you. Can you hear me? Audio okay? Wonderful. So what I will do is, and again, thank you. I was caught up in a validation study yesterday, south of Paris, but the meeting organizers were kind enough to let me present today. So thank you for that. What I'd like to do today is share a presentation on the benefits of artificial intelligence as a screening and a diagnostics aid in the clinical and pathology lab. And so let me go ahead and share my screen. There we go. And really quickly. Okay, we should be good to go. So today in the laboratory space, laboratories face many challenges, notably difficult working conditions in the microbiology department, and in particular the clinical biology department. The work is difficult and it's dealing with microscopes often, which is a 400-year-old technology that hasn't ostensibly changed since then. And a lot of the lab technologists spend their time as filters looking for things on a slide rather than actually playing their role as experts, using their expertise to identify and diagnose. And so this is a slide that you might recognize. It's a parasitology slide, a fecal sample. And I would like to know if anyone can find a Giardia on the screen. And keep in mind that this represents even more than a normal field of view, that operators have to look over 10, 20, 30, 40 of these to make a diagnosis. And in this case, our little friend is located here. And so you can see the challenges that are faced. Another challenge is quality assurance, reducing the interoperator variabilities, the biases, and ensuring ongoing training and certification are big challenges. As well as competition increases, labs have to be more and more conscious of turning negative contribution margin tests into positive contribution margin tests wherever they can. And there's a universal problem that we have noticed that is literally everywhere in all the geographies of the world. And that is that as the world's population increases, so do the average age of the world's population. And as the age increases, well, that means that more lab tests are needed. But at the same time, there is a worldwide labor shortage. And what this forces labs to do is find solutions. And so in recent years, major technological advances in lab medicine have improved the clinical lab diagnostics and monitoring, and they also further enhance the quality of patient care. And in turn, these innovations have added recognizable value to lab medicine in the healthcare sector. For example, traditionally in clinical chemistry, hematology, and microbiology testing, well, this was, as I mentioned, very laborious for staff who were responsible for the many steps involved in the analytical process, from obtaining the biological specimen to its eventual discard. In recent decades, however, clinical chemistry and hematology laboratories have adopted largely automated analyzers that have broadly improved the efficiency, the costs, and reduced lab-driven errors. In recent decades, notably advancements in genetics, genomics, nuclear magnetic resonance, spectroscopy, mass spectrometry, and microfluidics have also increased the laboratory's automation and made many new advances possible within the lab space, both in improving quality and reducing costs. The development, for example, of next-gen and single-cell sequencing has revolutionized the field of genomics and transcriptomics. And that allows a whole genome DNA and RNA sequencing, for example, for high throughput and lower cost than ever before. Then you've got the proteomics and the metabolomics that are advances in the MR and MS technology, NMR and MS technologies. And so the novel application, for example, of microfluidic technology has been readily applied to several laboratory tools, including the lab on a chip technology, single cell omics research, and even point of care testing devices. But today, I want to focus on one of the innovations that makes an impact across several of the above mentioned technologies, which is artificial intelligence. There are three enablers that we have today that make artificial intelligence possible. In fact, the concept of artificial intelligence was really well defended by someone you probably have heard of, Alan Turing, who was a British polymath, who suggested that humans use available information as well as reason in order to solve problems and make decisions. So why can't machines do the same thing? And this was back in the 1950s. But there were three things missing. And the first, as you can see, is the lack of computational power. Computers simply couldn't store enough information or process it fast enough. But as time went on, computers got more and more powerful. And today, it's in fact the gaming industry that has fueled the proliferation of very powerful GPUs, graphics processing units, that drive the artificial intelligence. The second enabler has been the fundamental limit of computer storage that 30 years ago was holding us back, but today is simply no longer a problem. You're all familiar with Moore's law, which estimates that the memory and speed of computers pretty much doubles every year. And that has caught up and in many cases surpassed our needs. And the third enabler is data. Artificial intelligence needs a lot of it. Big data fueled by our new storage capabilities enables us today to gather and store unfathomable quantities of data on just about anything imaginable. And so in the field of artificial intelligence, there's a thing called deep machine learning. And that's the field within AI that gives the computers the ability to learn without the line-by-line coding, without being explicitly programmed to do what we want it to do. I won't geek out on how it does it, but I'll just say that a neural network is a method in AI that teaches computers to process data that mimics the human brain. It's a kind of machine learning process that uses interconnected nodes or neurons in a layered structure that resembles the human brain. What it does is it creates an adaptive system that computers use to learn from their mistakes and improve continuously. That means that artificial neural networks attempt to solve complicated problems like summarizing documents or recognizing cars, road signs, and even cells and microscopic organisms with a lot greater accuracy. And so convolutional networks, neural networks, are distinguished from other neural networks by their superior performance with image, speech, and audio inputs. They have three main types of layers, which are the convolutional layer, pooling layer, and the fully connected layers, but I'm already geeking out too much. It suffices to know that the CNNs, the convolutional neural networks, are the core technology that enables us to make these advances in image recognition that we'll be talking about today. And basically, there's a discussion that comes up often, which is, what about AI versus the humans? Well, we view it as AI plus humans because humans are really good at critical thinking. We make visual and data associations better than computers do. But computers, they are able to scan without getting tired. They're able to look for things that we simply miss. And so on a pixel by pixel basis, they're simply better. So by combining a human with a computer, you end up with time saved, and that results in better results in less time. In comes our company, which is TechSite, and we are poised and aiming to become the leading digital diagnostics platform for clinical pathology and infectious diseases. I won't go too much into this, but this is a very brief overview of our company. We have three verticals: environmental, where we do airborne mold testing. We do veterinary, where we actually work with Zoetis on a very worldwide scale. We are doing millions of samples with Zoetis, where we are actually revolutionizing the veterinarian clinic and lab environment. And of course, our main focus, which is human. We have been mentioned in Forbes, CNBC. We just this month submitted our first FDA approval All of our products are CE-IVD marked and will, well, as soon as they get notified bodies, will be CE-IVDR marked. Just a little story around Zoetis is that we have been able to prove our platform and our technology on a very large scale by implementing on animals the same tests that we are running now on humans. And the reason that's been important is because it has both allowed us to test the technology, but also the scalability. We run on Amazon Web Services, and with Zoetis's sales force, they have over 900 salespeople worldwide. They've been able to prove the scalability of our systems. We are also very happy to announce that Mayo Clinic just chose TechSite as the platform that they will use for all of their future digital diagnostics testing. This also means that Mayo Clinic has already started developing new indications with us that they will then help us bring to the world. And so when I talk about the clinical pathology AI platform, you might just think the AI, that's the sexy part. But that's just one component. I mean, data curation in the AI algorithms is, I guess you could say, at the heart of it. But then once you have those results, you have to be able to do something practical with it. And as a company, we are not interested in just the R&D. We want to be very pragmatic solutions to our customers. And so then you start getting into considerations such as the image acquisition. While we don't make digital slide scanners, we do depend on having good images. And slide scanner manufacturers are really good at histology. You know, the AP side of things, having a nice thin section of tissue, it's easy to focus on. But when you get into the liquid-based mediums, it's a very different beast. And so we are working with scanner manufacturers, and we have become experts in image acquisition, security, and scalability with HIPAA, GDPR, and scaling our systems. The technical aspects have been a very serious consideration, and we have teams that do nothing but that. Same with regulation. We are very committed to remaining fully transparent and regulated, and we have a department who do nothing but our studies and deal with regulators. As well, we know that our technology is only as good as it can integrate with a laboratory's information system. And so we have developed and continue to develop a full open API system. And the last part that I will be showing you briefly as we go through the different solutions and the different ways that we can benefit a clinical lab are in the workflows, the actual workflows. We don't just have one interface. Every indication has its own particularities, its own details that we have developed in concert with our customers and the labs that we work with that help the technologist work faster and more efficiently. These are just a few of the scanner companies that we work with. There unfortunately is no silver bullet, universally good scanner manufacturers. Some of these scanners don't have 40x, 80x equivalent lenses. Some of them don't have a very good numerical aperture. Some of them are huge, very expensive machines, while others are, smaller machines that wouldn't be good for either large labs or smaller labs. And so what we do is we work with our clients to recommend scanners that would fit for their installation. And that's also why we as a company aren't interested in trying to create one miracle scanner, because A, it's a completely different field that requires decades of expertise to really get right. And B, it's just too complex. You can't have one scanner that does it all for everyone, because we deal with labs that handle tens of thousands of cases per day. And we also deal with labs that have 10, 12 cases per day. So what I'd like to do now is go over rapidly some of the ways in which artificial intelligence can benefit clinical labs today. The first is fecal and ova and parasite detection. Traditionally, you've got the microscopic approach, which lab techs usually hate. It's not very sensitive. It's subject to labor shortages, but you can detect anything you can see. You can use the PCRs, which has a great sensitivity, but it only detects the pathogens that are included in the kit that you've purchased. And it's very expensive today, and they aren't always reimbursed. And then you've got, of course, the antigen tests, which are rapid. They're not too costly, but again, limited targets, and they tend to be insensitive. Our solution today has been in operation at one of the largest reference laboratories in the US, ARUP, since 2019, where they have done well into the hundreds of thousands of tests per year with our system. Today, we support trichromin MAF, but by summer, we'll have our iodine wet mount solution, which is pretty much what the rest of the world uses. And our interface, what it enables operators to do is, rather than search for the objects that they're looking for, and I've listed them here, they simply confirm or challenge what the AI is proposing. And anecdotally, and here's the process. I want to get to the case study. Basically, what you do is you create your slides, and we do that using a little device called the Paracep. You then scan them in, the images are processed, and a few minutes later, the technologist can review them. But this is the part that I wanted to show, and it's that we have a sensitivity and a specificity both over 98%, which, as I'm sure you know, is well above what humans are able to do, with the consistency. And the best part is that the people that use our system absolutely adore it. They're no longer hunched over the microscope, and they've got their review time is well under 15 seconds, which is phenomenal for laboratories. We've also been published in the American Society for Microbiology with one of the studies that we ran with ARUP. And you know, when you've got in a normal clinical lab setting, over 85% of samples are usually negative. Well, that means a lot quicker processing times. But more importantly, it helps with labor shortages. And it means that you can help train using our system, but the system is also a lot more consistent than newer people can be. Hematology. Now, for hematology, we're not trying to solve the problem of the core blood counts, the CBCs, because the flow cytometers, the Sysmex lines, you know, they cover that very well. But in any lab setting, between 5 and maybe 10% of any lab's workflow get flagged for manual review. And that's where you get the bottlenecks created. And not everyone has the money to invest in, you know, the Celavision Sysmex line, which you could consider one of our direct competitors. And so what we do is we offer a much more affordable solution to the problem of the manual differential. And as you can see, it's very complete and allows operators the same interface that they're used to when they're giving the normal CBC. It's just that they simply confirm, or they can change the parameters so that the human always has the control over the final analysis that they give. And we also are able to identify the monolayer on the slide. And so we scan a bigger portion, and our software is able to even help with some of the more rare diagnoses. We were also published in the International Society for Laboratory Hematology with a paper where we had a perfect correlation, well, perfect. We had a very suitable correlation between the manual gold standard of manual microscopy and our software. And this is actually, we have submitted it. We are on schedule for our FDA submission. It's noteworthy the FDA has been good to work with in the sense that they understand that their entire paradigm is outdated with AI. Because what does FDA want? They want you to come out with a project, freeze it, never touch it, until you re-go through the FDA process. Well, obviously with AI, that's incompatible because the AI is constantly learning. And so while we've been obliged today to freeze development at a certain, you know, KPI level of sensitivity and specificity, they are enabling us with more streamlined process to update these versions. And in the future, we think that there will be provisions in the FDA structure that will allow for AI's continual learning advancements. The next is cervical cytology, the traditional pap smear. And so today, an operator uses either BD's SurePath or Hologic's ThinPrep slide preparation. We don't do manual prep because it's just too inconsistent. Even humans have a hard time sometimes reading manually prepped pap smear slides. You then scan them in, process the image, and review the images. Now, what that means is if you are involved with cervical cytology, you will recognize the samples. Instead of looking at fields of view through all that, we show the operator, the atypical squamous and glandular cells, all organized by their level of degradation, which makes it very quick for an operator to make an analysis. What's the goal in the PAP analysis? Is to find the most degraded cells as soon as possible. So if I find an L-cell, in essence, my diagnosis is done. Our interface and the workflow is completely based around the Bethesda specification. So it's fully Bethesda compliant, including specimen adequacy and the diagnosis that accompanies it. And what it does is it enables us to dramatically reduce the time it takes to analyze cervical cytology slides. Notably, we ran a study at a hospital in Mexico where we had 217, I believe, slides that had been previously marked as no further review. And we found 17, sorry, it was 200 slides, and we found 17 slides that were actually cancerous. And no, I'm looking at it right here. It's 300, yes. And we found 17 of them. And so it shows the advantage of having a system that doesn't get tired or distracted. And there as well, as soon as our FDA submission is done with hematology, this is going to be our next one that we will submit to the FDA. Next is bladder cancer screening. Now, this is one that we're excited about because in the US alone, it's the 4th leading cancer among women and the 10th among men and the 10th among women. But cancer survivors are supposed to be screened afterwards to monitor 4 times a year. But they never do it because it's a biopsy and it's extremely painful. And so today you've got what? You've got cystoscopy, which is invasive. It's time intensive. You have to go in, they have to go up in and take a biopsy of your bladder. And you've got the Eurovision. Well, the urine-based one is notoriously insensitive. So what we've developed is a solution that enables us to identify and more accurately monitor the status of a bladder cancer and even screen it without the invasive nature of the biopsy. Now, these are some of the initial studies that we have, which already show better results than the FDA-approved methods, which we're very excited about because we continue to improve it. And as we get it into the clinical space and start using it more and more with more clients, this will only improve. I'll talk briefly about digital FISH, where today, in addition to hemopathology, we will be looking at pre- and postnatal diagnostics, previously GTG banded and cytogenetic slides, karyotyping, and fertility studies. And here we're working with a fluorescent scanner manufacturer to enable this. And what it will do is it will offer the same advantages as our other indications, but applied to FISH. The next one I want to show you, the next area, is actually being handled by a company called Nanospot. Well, it's our company, but we have developed a small mobile agglutination test, which enables very quickly to analyze the COVID antibodies. Now, today it was COVID simply because it was opportunistic, but in the future it can and will handle other types of blood typing. And then lastly, I'd like to talk about bacteriology gram analysis. Now, the standard protocol has you start your culture plates, and that takes between 1 and 3 days. And depending on if the person was already on antibiotics, you can't be sure if it's going to grow in the culture. And so what happens? The lab performs a gram stain. And this takes several minutes, and it allows you to confirm the presence of bacteria and provides other indications. And then you go on to the MALDI-TOF, and then you go on to an antibiogram if your lab is really dedicated. Now, the alternative to that is PCR. And today they've gotten the times down But the disadvantage of PCR is most of the time it's not reimbursed. It remains very expensive, and you only get the organisms that you've paid for in the kit. And so you've got all of the same challenges as for the others that the labs face. You know, these things take time. You've got variability between operators, especially with bacteriology, and the costs. And so same process, you perform a standard gram stain, you scan it in, we process it, and then the technologist reviews the images. Now, our first indication was for BV, so the bacterial vaginosis indication, simply because it was timely. It's one of the high volume tests in a lab. However, our system is already capable to make reads on eye, ear, nose, throat, expectoration, synovial fluid, the pus, you know, the other sources on the body. And it's capable of classifying all the objects that you see here. We recently ran a study on BV, which concluded that we've got a sensitivity of 100% and a specificity of 88%, which is actually is better than the manual reviewing for gram-stained vaginal samples. And anecdotally, all of the operators said they were very comfortable making the reads. And so what's next in the laboratory? What are some of the things we're working on? Well, first of all, we just published a paper in the US at the ASCP conference. We have a poster there on AI super resolution. Now, without wanting to be cheesy, you know the CSI TV shows where they look at the license plate and all of a sudden you can read it? Well, that's what this is, and it does work. It might not be as sensational as on the TV shows, but what it does allow labs to do is take care of one of the problems you don't really think of, which is image storage. It costs money to store these images, especially when you're talking about gigabytes for one sample. It's a lot of money. And what this does is it enables labs to either lower storage costs or provide longer term storage, because you can downsample images and then simply re-up sample them if you ever have to access them in the future. On the screen, what you're seeing now is several of the areas, and this list is by no means inclusive. There are others that we are working on. What is in bold are the ones that we have already today, and what is not in bold are the ones that we are currently working on or preparing to work on. And the last one I wanted to show is sepsis, because Beckman-Coulter showed that sepsis can be detected with 26 complete blood count features. Well, our deep learning uses, to be precise, 4,096 features. And so we are very excited with this one. We're going to be developing it with Mayo Clinic. And when this indeed comes out, we're very excited at the potentials that it will bring us in the laboratory. So that's my presentation. Thank you very much for your attention. If you have any questions, I'd be happy to field them.
Perfect. Thank you so much, Mr. Bankhead. That was a wonderful talk. I have a question. Actually, for the peripheral blood smear or for the wet hematology, in addition to that, have you looked at bone marrow aspirate specimen in terms of using that for AI? And if yes,
a great question, and I can't believe I didn't cover it, because yes, the fine needle aspirates, or the bone marrow aspirates, is a solution that, in fact, Mayo Clinic, that was the very first thing that they were interested in, initially, without even the AI. And why do I say that? They have such a need for grouping their samples, because everyone has shortages of qualified people to do FNA reads. And they did several studies with us to validate our solution for remote analysis. And so today we have a solution for FNAs where we don't perform the AI, but it uses our system and all the features of the system to enable their pathologists or their hematologists to make those reads remotely. And even just that initial baby step has been enough for them to say, let's attack that first. And so probably in a few weeks, they will start using it. And so that's step one. Step two is, of course, finishing off the AI, which we have an entire team. You remember that diagram with the different circles? One of them is data curation. And that's actually where most of our people is in the data curation team. You know, every time you fill out a form online with the CAPTCHA and they say, identify the crosswalk, identify the buses, identify the cars, you're helping Google tag images. Well, we don't have that advantage. No one is doing that for FNAs, for bacteriology, for pap smears. And so we have to do it ourselves. And that's where we work with experts. And we have an entire ecosystem in our software that the end user never sees, which helps us develop algorithms quicker. And so step two of FNAs will be to get more samples, tag them, tag all the pathologies, all the organisms, all of the things that we want to be able to detect.
Okay, great, thank you. The other question that I have is with regards to the peripheral blood smear. So what power are you, scanning power or magnification, you're actually scanning those peripheral blood?
The peripheral blood, so for the complete blood counts?
Yes.
That's done with a 40x it's a 20x objective, but when you put the CCD, the digital image scanner, it in essence doubles it. So it's a 40x magnification digitally, and we use that. But more importantly is the numerical aperture, and so it has to be a minimum of 0.75. Okay.
And for instance, if we were to look at the peripheral blood smear slides or the bone marrow aspirate slides, and we wanted to, pan in and also just zoom in, zoom out, I just wanted to understand that what is the highest magnification that I could see? That is it 100x because 100x is under oil, or is it 60x? Is that because like the way the WSI digital pathology slides for H&E are scanned? So I just wanted to understand in your system, are the bone marrow aspirates or the peripheral blood smear are scanned in a similar way? And if the pathologist wanted to review those scans, aspirates or the peripheral blood smear slides, what is the higher magnification that they could zoom in or zoom out?
That's also another good question. I might have misunderstood your previous question. For our existing AI-powered complete blood count solution, it's 20x, 40x. But of course, for FNAs, you need to be able to see the granularity of the cytoplasm and other details like that. You simply can't get with that level of magnification. And so for that, that's where I mentioned that the numerical aperture is actually more important than the actual magnification, which, okay, you get bigger images, but not more detail. And so we have the Grundium scanner has a 0.95 NA lens, which gets you the level of resolution that the hematologists need in order to be able to perform the remote FNAs. And so the second part of your question was how do you zoom in things? One thing that I didn't mention is that of course our software is built on a very competent digital pathology slide viewer system. You can zoom in, zoom out, you can annotate, you can do all sorts of things with your slides. But for our commercialized indications that I showed you today, we really want to avoid the operator having to go to the slides. And so we'd rather them just look at what we're proposing and then either confirm or challenge that. But for the remote FNAs, of course, they need to be able to look through the slides, and we have a very capable system that enables them to do that. And it's all web-based, so they can do it on their laptop, on a computer monitor, whatever.
Great, thank you so much, Irving. Any questions from the audience? Wonderful. Thank you, Mr. Bankhead. It was a lovely presentation. Really enjoyed it. I'm sure everybody did. Thank you for your time. Sabina Soldati, you have a question?
Yes, sorry, I wrote it in the chat. I would like to know the publication you mentioned. Could you write it down in the chat?
Sabina, hi. You mentioned, actually, I mentioned several publications.
No,
Which
sorry.
one?
You mentioned that you published recently to a publication.
You mean the
on-
poster that we presented at the
Exactly.
ASCAP conference?
Yeah, yeah.
Oh, the poster. Oh, that's a great question. We just did a press release on it. While they continue the presentation, I'll put the link in the chat.
Yeah,
I think Sabina Soldani is referring to the ISLH paper that was published in on June 14, 2021. Is that the one, Sabina?
yeah.
Oh, okay.
Okay.
I can get you that link. I'll paste it in the chat.
Okay, thank
So
you.
the publications, Mr. Pankit, if you could kindly put it in the chat with a link, I would be really interested to know as well, like Sabina.
Yeah.
Will do.
And also, which viewer do you have?
It's our own proprietary viewer. Again, we've built an entire platform around this.
Okay.
And so our viewer enables us to, as I said, look around the slides. It's very quick. It's tile-based. It's web-based.
Yeah, so it's not a commercial one.
No. In
Okay,
fact, our
okay.
viewer is
Yeah.
like the foundation of our system.
Okay, thanks.
My pleasure.
Perfect. Thank you so much. Thank you once again. So we will move to our next speaker now. Dr. Hopefully we'll be here able to hear Dr. Vivek Anand from India. Dr. Vivek Anand, are you able to try one more time? You are on mute. Thank you. Can you unmute your computer, please?
Yes, I did that. Can you hear me now?
Yes, thank you so much. Sure, we are so excited to hear our keynote speaker. So, Dr. Anand, I wouldn't delay now. You can start your presentation. Training your brain in digital pathology, arriving in future.
Thank you very much. I welcome you all to arrive in the future today on the 5th of April. Finally, my patience has paid and I am able to talk with you all. And I want to take you all along with me on the journey to the future in digital pathology. Are all of you ready? And this is an interactive session. This is not going to be a lecture, one-sided lecture, because it's not only my brain has limited powers. All the brains put together, all the 23 brains present here put together can churn out a nectar, and that can help the modern medicine. So are you all with me? I cannot hear a response. Okay, so next slide, please. Next slide. Digital biopsy. We all know what is digital biopsy. I want to show you what we can do using digital pathology techniques like scanners, AI, artificial intelligence, virtual reality. Yesterday, I've been listening to a lot of erudite speakers talking about contrastive learning, deep graph informa, HES training data, and Madam Dr. Radhakrishnan also from UK spoke on artificial intelligence. She enlightened on tumor cells, immune cells, stroma cells. So basically, I want to use the digital pathology techniques, the scanners which have been developed now to detect cellular changes in the cytoplasm as well as nucleus. For example, our NC ratio, nuclear cytoplasmic ratio, hyperchromatism, sizes of nucleus and cytoplasms. We say in anaplasia, the nucleus starts growing in size because of its DNA and mitotic activities. So can we not use the increase in the gradual sizes to detect through digital pathology like techniques? Can we not develop scanners which will allow us to which will allow us to detect the changes that are already going on inside the cells? And I shall later on come to something called as a digital biopsy. I cannot see the videos, so can my videos? Can I have some help with my videos, please? I cannot see anything. I do not know. Today the technology is playing games with me. I've been trying to give whatever little knowledge I have to the world so that tomorrow's our young doctors like you are our future, can take it from me and start developing into it, start thinking on it. So if I can see the video, I should be happy. No, don't go to the next slide. Later, yes, read the. I don't know whether I can, whether I'm able to be here. Can I be heard? I am not getting any responses from the audience. I need some responses from the audience because this is going to be an interactive session between myself and you all. So unless you all interact, or unless the moderator interacts on your behalf, I may not be able to communicate much. So Dr. Sadaf, can you please communicate with me?
Yes, we can hear you, Dr. Vivekanand, and I'm putting the thumbs up sign that we are able to interact with you as well. And I speak on behalf of all the attendees as well.
Okay,
are you able to share the screen at all? There is a green button. It says share screen. Do you want to try that and see if that works?
Where is that green button?
So if you see on the Zoom screen, the bottom of that, there is mute, stop video, participants, chat, share screen. That green share screen button, you can click on that. That would share your screen. Whatever you are seeing will be able to see that. Or alternatively, the organizers, they could just, if you say next slide, they'll switch to the next slide.
I think so. I think I am tired waiting since morning and 10:30 in the Indian Standard Time. So I think I just want to share my thoughts with all these younger generation so that take it up from there. And before anything happens to me, I should be peaceful that I have shared my thoughts with you, madam. So you can share with them, and maybe they can react through you with me. So basically what I'm trying to make a point here is, let's go a step ahead of digital pathology. And now we have scanners which are transferring the slides to the computers. That is an extremely nice thing. We have also been, since yesterday I've been listening, and we have also been discussing about artificial intelligence, contrastive learning. Just now, my predecessor speaker, I think he was from USA, spoke very nicely on artificial intelligence, and I congratulate him for that. I'm sorry, sir. I could not catch your name. Please forgive me for that. But you spoke really well, and I appreciate all the knowledge given by you. So my point was, how can we use this artificial intelligence to turn into virtual reality or absolute reality, not just virtual reality? So we can go to my next slide now. Thank you. To detect mitotic changes and DNA activities. Can we develop techniques to detect the mitotic changes through detecting color changes? See, we have hematoxylin and eosin. Yesterday's first speaker did talk about hematoxylin eosin technique. which has been generally widely used all around the globe to detect the pathology, and we have been living with it since ages. Can we replace this tense? I'm going to come out with that in the next slides. But can we encourage, can we have these stains, the changes in the colors taking place inside the body? And yesterday I saw many colors, including brown and yellow and violet, and I was happy. So my thought, my churning of brain and my churning of your brains is, can we all as pathologists, can we develop techniques to detect the mitotic changes through detecting color changes in mitotic figures and DNA activities through hyperchromatism? Once the color of the cells increases, can we not tap these color changes through laser-like scanners to detect these color changes from the normal to abnormal, and try and detect beforehand the changes taking place at the cellular levels, both in the nucleus as well as in the cytoplasm. Cytoplasm, we could also want to detect changes in the mitochondria and other cellular organelles, including the cell wall, and to detect where the NC ratio, how it is getting changed, whether nucleus is growing in size, whether cytoplasm is becoming less, whether also whether we can try and see the changes and can find a technique where we can detect the changes in the DNA activities, where we can detect the changes in the chromatism, because hyperchromatism is our very valuable sign. And whether we can detect the hyperchromatism or other changes and to formulate what I call as light gun non-invasive biopsy. I've been teaching my student with the conventional biopsy, incisional biopsy, excisional biopsy, punch biopsy, aspiration cytology, etc., etc. But time has come. Now we have digital pathology. So why can't we have a non-invasive light gun, non-invasive biopsy, by which I mean to put a thought, to present a thought in front of all of you, is along with your engineer friends, along with your technical brains, along with your technical friends, can we not all get together in the world from different countries and try to find out a laser-like gun which will only emit light, and the light can capture the radiations which are emitted by the by the cells, by the cells themselves. The different color changes taking place inside the blood, inside the nucleus, inside the cytoplasm. Can we not detect these color changes periodically in advance and say that this is a pre-malignant condition, or this is the onset of anaplasia, and there are changes taking place in the either in the leukoplekic cases or the general cancer cases, which involves a lot of anaplasia. Anaplasia is the key to detecting all the oral cancers, and if we can catch the anaplasia in initial stages, I am sure a day would not be far when metastasis rates would drastically be brought down. Is Madam Sadaf there? May I have a reaction from her, please?
I'm here.
What do you think about this, madam? You are a very prominent doctor and a pathologist in the world. I don't know much about you, but you are a genius, and you have been conducting the session. So I would want to hear from you any questions or anything so that my brain can be churned.
Sure. I think the ideas that you are sharing, they are beyond digital pathology. And so you are actually looking at the different techniques to detect the mitotic changes through different colors, which is a new idea, and going, beyond the horizons of H&E or conventional staining. So I think it's pretty good. So we wanted to hear more about you, and we will be happy to take the questions in the end. And I'm sure I will have a lot of questions, and our audience will have a lot of questions as well. So,
Madam, I feel like crying because after so much of waiting, you have got my thoughts very properly. And don't worry about my life, but even if I go, please take them forward and work on these thoughts, and let us slowly replace H&E stains and other stains with other things also. So 1 minute I have lost my slides. So can I get to see my next slides? I have put it on another mobile, and it would tell you how stains would be replaced with digital pathology techniques. But till then, if you can continue talking, then I shall try and get my slides back again. I'm extremely sorry for what is happening today.
your next slide is up, Dr. Vivekanand. It's up. So we are able
Madam,
to
you can call me Dr. Rege. That will be simpler. Vivekanand is a very, very heavy name, and for me to carry.
Okay,
So
sure.
you can call me Dr. Anand. Anand is happiness. You can call me Dr. Anand.
I'm okay with any. So yeah, we are able to see your next slide, which is stains out, chromatography in. That seems exciting.
Yes, I think it must be talking about the stains, because I have lost. Okay, it is about replacing staining with chromatology and chromatography by using color coding, detecting chromatic changes using DP-like scanners. So what I intend to show in that, what I intend to put a thought in all your young minds is, same way, can we replace tomorrow? It should happen that we should not be able to put our hands and fingers in the stains. So stains and microscopes also will be passé, and we will develop techniques, the rays, same like how X-rays were developed, and the X-rays could see through and through the bone and the bone marrows. And today from X-rays, we have gone to ultrasonography, and we have PET scans, and what you may not have. We have advanced so much. So if we could advance in radiology, my question to all of you is, why can't we advance in pathology? Why do we really need microscopes? Do we really need stains? Do we really need glass slides? My answer to the last question is, now we may still be using glass slides, but we are transferring the images on the computers, and we are converting them into digital pathology. So pathology, if it could be converted into digital pathology, why can't we? And in dentistry, we have the light cure, with which we do a lot of fillings, and we change the dentition of a patient. Why can't we change the pathology? Why do we need to have the staining bottles? We do not need to have the staining bottles. Instead of the human staining the tissue, let the body under its pathology, which have changed the colors from light blue or normal blue to hyperchromatic. We have got a term in pathology, hyperchromatism. Chroma is color. So why can't that hyperchromatism be detected with chromatography or chromatology? Chromatology would be the science of studying the effects of light. And chromatography would be the art of detecting the pathological changes taking place in the different colors in the cells. And I'm not talking of only malignancy. In my future slide, I'm going to talk also about other pathological conditions. But as of now, I just want to put into your minds, how can we, as I was talking about that non-invasive light probe for biopsy, and we do away with, we cannot totally do away with excision or incision biopsies, but at least we can change the life of so many children, so many adults who are very anxious of hearing the word biopsy, because biopsy is associated with taking, what does biopsy mean? Biopsy means taking a sample of the tissue out of a living body. And that I want to stop all that practice, and I want to turn it into a non-invasive practice of detecting changes in, I would, in my last slide, would come on to using saliva instead of blood. So instead of, and I am very much thankful to UCG conference and Dr. Annie Pascal for giving me a chance to showcase in front of the world. Many of you may not have been knowing it. I showcased to the world on 21st of December in the UCG conference of gastroenterologists and renal people and pathologists and pharmacologists about VSSR. That's my initials of my name, Vivekanand Shanta Shripad Rege, technique of surgery without anesthesia. Without anesthesia, without lasers, without hypnosis, without acupressure, acupuncture, and without yoga. So same way, I want to use this platform to put in your minds, how can we stop using, how can we stop or cut down using the staining method and use the chromatic method to detect the color changes, not only in malignant, but in all the pathological cases, like how the urine changes color from colorless to a straw colored, to a brownish, to a deep yellow, to reddish. So, and the stools change colors from normal to the black stools. So the colors are taking place, color changes are taking place in pathology. So we need to brainstorm on this. And I want the conferences, all the global conferences, and should take Dr. Vivekanand Rege's these humble thoughts and dwell upon it, how you can change the world from an invasive biopsy to a non-invasive biopsy. Madam, please comment something on this, whether it's possible, till I search for my slides. Thank you.
I do have a question in the chat box from
Yes.
From Ilerwala. Please pardon me if I didn't pronounce your name correctly. The question is how to differentiate a true mitosis from other architectures such as apoptosis corpus in digital pathology technique. Is there no risk of errors as with the simple microscope? You're on mute, doctor.
Human as well as human errors as well as machine errors. You just saw it's because of the errors I couldn't connect with you in the morning to give my keynote address. I'm so sorry. Forgive me. You are talking of apoptosis and simple microscope and digital pathology. You have to take into account the human errors first, because the errors that can happen from person to person cannot be gauged properly. And besides, the human errors depend on a lot of things which I cannot dwell into just now, because it not only goes into, are you hungry, or is your stomach full, to are you happy or are you not, or I being also a management expert consultant, it also depends on how you are committed to your work. Committed is commuting, how you have traveled to your work. If you have traveled in a happy way, your work will be excellent. You have traveled in an unhappy way, you have not got a seat, to sit down, you have not, your co-passenger has been troubling you, your work will get automatically affected. And that affected work, affected mind will translate into increased percentage of human errors. That has to be taken into consideration. As for coming into your microscopy and differentiating the change, what one person may say is anaplasia, the other person may not say. He may say something like some other terms like acanthosis, apoptosis, or any other things. So basically, there is a gradation changing from person to person, which we have to take into account. And if say 8 out of 10 pathologists say, oh, this is definitely an anaplasia, or this is definitely a keratin pearl, then it has to be a keratin pearl, because you are taking 80% of chances of the people, of the human brains. And that's exactly I'm saying, madam.
Hi, good afternoon, everybody. I have a session just after a while ago.
Yes. Yes. I would love the questions.
Sure. Dr. Anand, why don't you finish your talk and then we'll take the questions at the end.
Okay, as you say. But
Yeah. Well, if you do that would be nice. If you finish your talk, in the end, we'll be happy to take the Q&A question and answers session in the end.
No, because I was happy to tell Madam Pascal that I would have loved it to be more of an interaction session, because it's about 40 minutes. And I want the participants in this August conference to churn my brain also. So that was the reason that I wanted it to be, because I am not an intelligent man. So there are, like this doctor asked about errors, I admit and I accept errors in my talking, my thoughts, my ideas. So I am just putting only germ of ideas in front of you all, August audience, so you can work on it and you can make them better. The sons are always better than father, and daughters are always better than mother. So that's why I was looking forward to an interactive session where I can learn from all you young people something, and I can polish my thoughts well. But that's the reason I wanted to hear your opinion till I search for my slides. I hope I have time. If I am taking time, then I do not want to disturb you, and I will just go run through all my slides one after the other. But in the meantime, if you can comment on the thoughts that I am giving it to you, and if you can ask the audience is what are they thinking, and if you can convey them to me, I shall be highly obliged. Thank you.
So, Dr. All the audience, their thoughts are right now that if you would kindly give us your talk and all the slides, we would love to see that first, and we will ask the questions in the end.
The problem is I'm trying to, on my another mobile phone, I had put all my slides, and suddenly somebody tried to disturb me by calling, and I have lost those slides. So I'm trying to search. Can you please read out the next slide, and I shall elaborate on it.
The organizers, can you please move on to the next slide? Sure. So we can see your next slide, Dr. Anand. You can explain that to us.
Okay, I shall try to see it myself. Wow.
Chromosonic gun. Are you able to see that?
1 minute. The next slide, chromosonic gun. Chroma, as we have seen, is light, and sona, as we know, is sound. And now we have ultrasound. I am basically a senior dental surgeon with 41 years of practice in South Mumbai, and in that I've used this ultrasonic scalers, which emit vibrations, sound vibrations to break the calculus, which are the small stones present in the gums, under the gums, to break them and to wash them out with a jet of water. So, and in ultrasonography, we are using ultrasonography. So, Madam Sadaf, my thought was, can we join sonography with chromatology to develop a gun using sound waves along with VIBGYOR is our violet indigo, what we all of us know. Yesterday, that Madam Radha Krishnan, she touched the point on the colors black. Now, I don't know whether we take black as a color or black as absence of color. But anyway, she showed pathological histopath slides with black, brown, violet colors. And I was extremely happy to see these colors, because if we can tap the VIBGYOR, if we can develop a chroma. So my first gun, which I showed in the last slides, was only a light gun, where the light trying to detect the changes in the chroma of the cells and the cell cytoplasm. But in this chromosonic gun, can we also incorporate ultrasonic? And can we formulate one gun which will use both the ultrasonic waves as well as chromatic waves? And it would be a light and sound combination. My young doctor researchers and students and followers, can you please use your intelligence to computate, to formulate a gun, this chromosonic gun, which will use this, detect and catch early the pathological changes by sensing the darkening of the anaplastic, not anaplastic nucleus, thus diagnosing the malignancy and moderating the gradation in metastasis of anaplasia in all the cancer cases. By this I mean the way our blood starts thickening, or the way our blood starts becoming red, or the way our skin, our nails and our conjunctiva inside the eyes starts becoming pale, or the way we see the gums becoming pale, the gingiva, and we try and detect anemia. We detect anemia through the changes of the color. So through the same principle, can we develop a gun which will immediately and intellectually detect the color changes in the shades of this color, not the color changes only in the color, not just stools changing from light brown to black, but the stools also changing from light brown to deeper brown, to deep brown, to deepish brown, to brownish, to dark brownish, to slightly blackish, and so on and so forth. Sometimes in diarrhea and dysentery, we get the green colored stools also. So and when we eat the beetroot, you can see our stools taking that beetroot color. So that means the body is full of light, like the body is full of water and matter. The body is full of light. So can we use this light to detect the pathological changes? Number one. Number two, I am a Hindu, but I am a secular person, and I believe in Vasudhaiva Kutumbakam, which means Earth is one big family, and we are all the same people, and our family includes the plants and the animals also. So we have to be caring and loving to everybody. Why I said Hindu is because Hindu mythology says a child, not a child, an infant, a fetus in the womb can learn through his mother or through whatever he hears when he is developing fetus in the uterus of the mother. If that theory is true, I had been to IIT Bombay and I told them, why can we not have class detection or classes where we can only bombard with the positive thoughts to the fetus in the womb of a mother? And the same thought I am bringing to all you qualified, intelligent pathologists from the world. My family, you are all my children, you are all my family. So, my dear children, can we not use these sound waves to detect the changes which are taking place in the pathology of the body? If the heart murmur changes according to heart disease, if the brain waves change according to the thoughts, the emotions, and if the body reacts to a loud noise, loud music, and the body reacts to peaceful music, that means the changes are taking place in the body at the cellular level, which we all pathologists should agree. That's why I wanted an interaction session, because I am basically a teacher and I need my students to interact with me. Whether I am saying something false, like my surgery technique, I called it, is it a myth? VSSR technique, surgery without anesthesia, is it a myth or a reality? And I showed to the world, and I want the world to question me, because unless I am questioned, unless that young pointed out the mistakes between apoptosis and simple microscope, we cannot improve. So can we formulate this chromosonic gun, my dear pathologists, where we can incorporate both the light and the sound to detect the changes, to detect the sound waves emanated from the pathology. When the starts, what does it mean? Is it sending some waves, or sometimes our changes in the throat takes place? Hoarseness of voice is one of the signs given by American Cancer Society as the initial signs of changes in the cancer. I have been, madam, I don't know if you can see me folding hands. I have been asking the American Cancer Society, and now I'm requesting you all pathologists to incorporate narrowing of the opening of the mouth as one of the major initial signs for the starting of oral cancers. So kindly help me in putting to all the cancer societies that you include narrowing of the opening of the mouth as one of the initial signs of pre-malignant lesions in oral cancers. Having said that, again, thus trying to develop and use a non-invasive probe for biopsy. One probe, what I thought into your minds was digital scanners like digital pathology to detect changes. Number two is the chromatography, chromatology, a light probe, non-invasive biopsy, and the third is chromatosonic gun to detect initially the changes in the pathology, not in the malignancy, but in the overall pathology. Next.
Okay, thank you. Actually, we are running out of time, and our next speaker is due to give the talk. I know because of the technological issues, we had to go back and forth. But with the interest of time, I would really apologize that we may have to announce our next speaker. But thank you so much for coming together.
May I just run through the slides without speaking? With the permission, yes. Multi-diagnostic biopsy probe, diagnosing not only malignancies, but also pre-malignant conditions and other general pathological disease conditions through sound and chroma technology remotely. Next slide, please. Feel good, use of endorphins, especially anandamide, in restricting anaplasia and in controlling metastasis in malignant tumors. For the want of time, I cannot explain this. And blood, bye-bye, saliva welcome, replacing blood samples with salivary samples as the future non-invasive method of diagnostic samples as DNA analysis. Next slide, please. Dye-less detection. Can we detect blood flow and clots by chromatic and sound changes within instead of a chemical dye that may be hypersensitive to some? Next slide, please. This is not important. I do not have to showcase my knowledge and my degrees and my attachments. So this slide is redundant. Thank you all for listening so patiently, and please work on my ideas, whether I am alive or not. Please take it through and give the world a better future. Thank you very much.
Thank you so much, Dr. Anand, for the wonderful talk. I would take the opportunity to invite our next honorable speaker, our keynote speaker, Dr. Richa Saxena. She's the Associate Professor of Pathology at University of Minnesota from United States. She will be giving her talk on the evolution and revolution of digital pathology in the preclinical pathology curriculum. Dr. Saxena, please welcome, and I would like to invite you on this Zoom meeting to join us and give us your wonderful talk.
Hi, good afternoon, everybody. Oh my God, there's some problem. I'm sorry, there's can you hear me?
Yes, we can hear you.
I think there's some issue. I don't know what happened. Like, let me.
No problem, Dr. Saxena. This is there is no slide on this. Maybe you can show us your saved slide, or the organizers pull up the presentation that you have, and then if you can say next, they can go to the next page, and we can go through your
you know, कैसे क्या करना है बोलना जरा.
Organizers, do you have Dr. Richa Saxena's slides with you?
Actually, I sent it to Dr. Pascal. I don't know why Dr. Annie, and I don't know why it's not opening.
Sure, let me connect to them, and they'll be able to share your slides. And then if you say next, they will go to the next page.
Got it. So it is so let me stop sharing, and
Yes.
if I already sent the PDF to Dr. Pascal, if she can do that.
Sure. Alternatively, if you wanted to share your PDF, share your screen, you can do that as well. The email that you have sent, you can open that and do the share screen, and we will be able to see that as well. The UCG conference organizers, do you have Dr. Pascal's, Dr. Saxena's slides? Can you please do the slideshow for us? Okay, so Amal is doing that for us. Here we are, Dr. Saxena.
Okay, thank you so much for the help. I hope you can see the screen as well as, but let me see whether it's moving or not. So you will move, I don't have to move, right?
Exactly. You will say next slide, and the organizers will be able to do that for you. Thank you.
Thank you so much for sharing the screen. And so I'll be speaking on evolution and revolution of digital pathology, particularly in regards with preclinical pathology curriculum. So please move on to next slide. So let me talk a little bit about the evolution of digital pathology. So although digital pathology is considered to be a new and emerging technology, the concept has in fact been around for decades. The first mention of methodology resembling digital pathology is over a century old. At this time, scientists were transferring images produced by microscope onto the photographic plates to capture the images and store them. This enabled the images to be referred back to when studying new cases of the same pathology. It also allowed the images to be shared with experts from other laboratories to gain useful insights, as well as sharing them with those learning the scientific discipline of pathology. Like methodology was used for medical education. So in other words, I can say the technology, this digital pathology like methodology was used for medical education purposes for a long time ago. In the late 1960s, the practice of telepathology emerged when pathologists began practicing their domain at a distance, gaining easy access to glass slides, images across various locations. We all know that NASA's adoption of telemedicine technique popularized the idea of the approach, as they were able to monitor the health of their astronauts at a distance using the telemonitoring system. Later on, telemedicine technique were used on the ground too. So, so this was little bit about the evolution of digital pathology. However, it has been only last 20 years when telemedicine has begun to see a widespread adoption. Back in 1990s, whole slide imaging scanners become commonly available, and this was a turning point for digital pathology. Before this, the laboratory professionals were unable to produce images of the entire slide. So now we can do the whole slide imaging. That time it was like they used to take some relevant portion from the slide and then they do imaging part. And the 90s also has, that was the year 1990s when there was rapid development of computer technology. And finally, hardware and software were available to carry out data management required for digital pathology. Okay, so the advancements, the advancement of the methods grow over a time and high resolution images were produced. Finally, so there is some I can say something in box if one can speak about that, because that is taking my attention. There's something like organizers about the mail or something. So please let me know if you can clarify this.
The organizers, can you move the slides, because we're just seeing beyond microscope, the game-changing world of digital pathology. And Dr. Saxena,
so I'm going according to the topic. The topic is evolution and revolution, and I'll go to these like education, telepathology, research data development, automated image processing. These are all the revolution. So I was just wondering about the evolution, how it evolved, and it was so I tried to explain that it was century old. And then we were using, I think if you remember, during my time when I was completing my MD degree in pathology, we used to click pictures through the microscope. And that is another form of digital pathology. So that is a similar methodology. So I'm trying to speak about the evolution. And then in 1990s, when computer era came, then we developed the software for all those things. So this is the telepathology, which I talked about the evolution of telepathology, consultations, revisions, and panels, then how it helped in the development of the research data set, and ultimately automated image processing. So ultimately, this advancement of the methods grow over the time, and high resolution images were produced. Finally, the current software is replaced for a more automated software, and which can even do quantification. So nowadays we can do quantification and others. So in conjunction with AI, particularly artificial intelligence, digital pathology may assist with the tasks strenuous for pathologists, and you can say for human assessment, human quantification. So that's how this future of pathology is digital. And these technological advances and the increased focus on precision medicine have recently paved the way for the development of digital pathology-based approaches for quantitative pathological assessment, and they can extract information beyond human perception. So this is improved medical care, and that is particularly through precision medicine, and then decreased transfer to regional hospitals, faster diagnosis and treatment. Again, this is a tailored medicine which can lead to faster diagnosis and treatment. For pathologists, it is kind of we can gain a second opinion within minutes and seconds. We can send these images to the other pathologists. So this cross specialty sharing for second opinion mattered a lot. And after all, this gave us the way to diagnose the things at a fast pace and more accurately. So then third one is for organization. For organizations, there were many advantages, because the digital pathology in the organization, there is storage of large amount of data in a centralized location. And with integration of digital workflow software that allows various processes and improvement in this data from time to time. Then less movement of pathologists, so there was more efficient, and ultimately it is easily transportable technology. And ultimately nowadays we are generating highly precise readouts of digital pathology.
Dr. Richa,
Now,
could you please guide us by saying next?
Oh, sure. I will do that. So you are actually, in fact, you are doing it rightly, very correctly. So I found, like, because maybe Dr. Memon, she is listening it carefully and she is doing it as soon as I finish. I don't know, but in fact, it was going on smoothly. So that's why there was no need. Now I will, if you want. So I will do that also.
The organizers have control. I don't. So I think that they're doing it correctly. You're right.
Yeah, they're doing it. Yeah,
very effectively.
And that is much appreciated. Like, they are doing it so accurately as if I'm doing it on my own. So this is this was the evolution and revolution of digital pathology, which was century back, and how it has been developed now. In fact, we are the one in the center now. Because of this digital pathology, we are in the center. So we are giving the diagnosis for precision medicine. Now, for me as a professor, as a teacher for a long time, this breaking boundaries and unlocking the power of digital pathology in modern curriculum is very important. So as you remember, during COVID-19 pandemic, digital pathology proved to be the crucial in the not only in the delivery of the diagnosis, but also for the education point of view. So nowadays, pathology is the key to understand medicine. We know there's a bridge between preclinical and clinical sciences. So even in some of the schools in the US, it is included in clinical sciences, because now pathology is the center. Now, digital pathology is pushing the boundaries of what can be achieved in pathology, training, and assessment. Use of digital pathology is in preclinical classes is for a long time, and it helps to define the standards of undergraduate medical education from one country to another, and even within the same training program. So everything is standardized. We are looking at the same slide. The students are looking at the same slide and the same area. So it helps not only in it is not only in uniform, so like you can say equity and diversification, but also it is helping in assessment part, because sometimes in glass slides we used to show different part to different modern curriculum. Now, next slide, please. So as I discussed, like during COVID pandemic, when the routine classes were off and we were doing online classes, so digital pathology was utilized in asynchronous learning. This asynchronous learning, as you all know, is anytime, anywhere learning. So the students can access material as per convenience, and they can do it at their own pace. They can conduct, even it is for the resident who can conduct research without interruptions. So this is asynchronous learning, means the mentor is not there. They have some recorded videos, recorded images, and these images are incorporated into clinical convenience. So we shifted, initially we recorded the video in so they were recorded. We were using a software called Panopto, in which we recorded these slides, and these were available for later utilization by the students for asynchronous learning. So next slide, please. So this asynchronous learning using digital pathology enables self-paced learning and offering students the autonomy to manage their learning experience. So in traditional class slides, there were the potential for image is not as enhanced as in digital pathology, and the students were able to learn exactly the same tissue section. Microscopy sections on glass slides show variability with regards to quality control, which may often be incomplete and not identical, for leading to discrepancies in testing and scores of the students. So these variabilities can be we were able to eliminate with digital imaging compared to glass slides that are prone to fading, breaking, and loss over time. Next slide, please. So this was this asynchronous learning using digital pathology was a pliant approach, reducing the necessity for scheduled meetings between learners and educators. They have the content and they were able to, so this is the content, they were able to take the switch on the Panopto and they can see it anywhere at their own convenience. So, and the quality of images were so good. So they developed an interest in this correlation, clinico-pathological correlation, and this provided the revolutionized way of teaching learning are done in medical schools globally, and would create opportunities for beyond the classroom teaching in form of synchronous learning. Next slide, please. This also fosters a flexible educational environment that can better accommodate students' diverse needs and lifestyles. So this pathology course in medical education, this include different kind of elements, such as we have formed learning objectives and we have learning goals. And then we have virtual microscopy as well as small group sessions woven in case-based learning scenarios. So in virtual microscopy, lessons includes like one teacher and 12 students per professor, and the specimens are scrutinized and allowing similar standards for each and every student. Next slide, please. So we also done one experiment, like initially we recorded the digital pathology videos with relevant clinical correlation during case-based synchronous learning. And then we uploaded these videos on Panopto. Then what we do, we observed how many times they were views for these videos by the students. So we measured it after every 15 days. And we observed that initially after the finishing this digital pathology, this case-based learning scenarios, there were a lot of views. And after the class, as part of asynchronous learning. And then before exam also, there were views, not as much as after the class, because they learned it after the class at their own pace of time. But of course, the views were there for asynchronous learning of these digital pathology images just before the exam. So next slide, please. Digital pathology has so many prospects for faculty as well. So in digital pathology, we have certain advantages. We can annotate the slides, which we were never able to do in the traditional class slides. And this was quite difficult and even imprecise. We were using a scanner and we were using an arrow, and then it was not that accurate. Here we can very well annotate the slide, and this becomes a lot more easy because same annotations can be there for every student and they can learn easily. And then, because of WSI, we can accurately and distinctly label the slide at multiple places, like somewhere there are mitotic figures, somewhere there is some other pathology, and they can easily visualize and or sometimes even specific structures of interest or areas of diagnostic relevance. So we can annotate all those areas. This was particularly important while studying neoplasia and various ISCs. Digital pathology also empowers the faculty to manipulate and tailor each slide to fit the need of the curriculum. So we can make these slides according to curriculum, whatever our learning objectives and whether they are meeting the learning outcomes or not. Then incorporation of visual slides into advanced learning settings, such as clinical case-based scenarios. And this not only generate interest, not only it becomes, it makes the learning environment lighter, kind of fun learning, but also it provides great opportunities. So one can easily guess, suppose we can, for undergraduates, if the most interestingly I found myself that focusing mitotic figures and differentiating between benign and malignant tumors during our in undergraduate sessions generated a lot of interest because they were able to find these mitotic figures at different shapes. Sometimes these are bizarre shapes, and this generated a lot of interest. Likewise, tumor stroma and other things also. So they were able to diagnose through digital slides, and then they were able to correlate it with the clinical case-based scenario. This was extremely effective in system-based curriculum and assessments. So as I discussed earlier, for assessment point of view, digital pathology proved excellent because these students were shown the same area and the same slide, so they can easily there can be no discrepancies, no. So it was quite kind of equity in the diverse environment. So this proved very great for assessment, both summative and formative assessment. So this has excellent pros for faculty. And next slide, please. So again, there were so many prospects of using digital pathology in preclinical pathology education for learners, because this was centralized pathological resource delivered to many students at the same time, similar slides, similar similar digital pathology images at the same time to many students simultaneously. And they all view the same slide, whether in small groups, and it was even useful in large groups as well. Next slide, please. So then for learners also creates an opportunity to interpret how a particular disease process might be viewed in a living patient. So because it was woven with the clinical case-based scenarios, and then we were giving the corresponding digital pathology slides so they can easily infer how a disease process can be viewed in a living patient. Next slide, please. And also there is deep understanding of visual interpretation and diagnostic decision by objectively deciphering the diagnostic process at a granular level. So we always try to make them feel as doctors. So when they were able to diagnose whether this is a malignant or benign tumor, or whether it is highly aggressive or grade 1 tumor through digital pathology, which was easy for them, seeing the number of mitotic figures. And there are certain other aspects made them feel like they are able to diagnose the disease. And next slide, please. And last but not the least, it makes the subject much more interactive and stimulating. So, there are certain parts for education, and engagement plays a major role in for learners as well as for the mentors. So this digital pathology, enhancing this student engagement, and they were able to interact, they were able to learn, and they were able to decipher the diagnosis. So student engagement and fun learning as well also was very useful for the students using digital pathology. Next. Then interaction also become easier for the students, and there were effective discussion on the content. There were group thinking in small groups, and their findings were shared among students. And it was also a useful strategy in using in team-based learning, where we made teams with great precision, both good grades and the grades, average grade students were in one team, so they can discuss and they can easily learn the tissue, the image, and they can easily lead to the clinical part as well. Next, please. Problem-based learning was also, we used sometimes, many times digital images for problem-based learning as well. And solving complex clinical problems became a lot less complicated. As in future practice, they should think as a future physicians, they have to go ultimately reach to a diagnosis, and they have to learn to solve complex clinical problems. So at this stage in clinical medical education, when we provided with digitization, it becomes less uncomplicated. Next, please. This was another interesting thing which I noticed. I presented this red pet integration in American Society of Clinical Pathology, and I got it was considered as the second best poster. So this was long back. So we integrated radiology as well as pathology. If you remember, during our times, we were using museums. So these museums were for the gross pathology, like gross specimen. So these museums were these images. So nowadays we seldom use. We have digitized gross pathology as well, And particularly, there's one colleague in Singapore, she is using digitized gross pathology. But what we did was, so digitized gross pathology images are not available everywhere and not for every tissue, not for every organ system. We use radiology, and we correlated this radiology with microscopy. Like, for example, glioblastoma. Glioblastoma in brain, it has a typical radiological image. Sometimes it causes the midline, the only tumor which causes the midline, butterfly tumor. And then sometimes it goes, and it has a dense inflammatory edema. So we can easily recognize in radiology image. And then it has a specific digital pathology as well, like pseudo-palisading arrangement and the marked necrosis. Also, we sometimes connect it to molecular pathology also. So integration becomes very easy with digital pathology because one can enlarge, one can clearly see whether it's a pseudo-palisading or palisading arrangement. One can very easily see mitotic figures, and one can easily find that what is happening here in radiology, and they can easily correlate. And then, of course, we give them the clinical findings as well. So we can identify the areas of diagnostic relevance and their application in clinical settings. So this red path integration was very easy, and radiology not only proved interesting, but sometimes it becomes a substitute for gross pathology images. And then along with clinical cases, it facilitates understanding of key histopathological aspects. And next, please. Now, this is the Bloom's taxonomy, which we use for assessment, knowledge, comprehension, application, evaluation, synthesis, and analysis. And digital pathology proved very useful here as well. So because the conventional challenges linked to the discrepancies in microscope and slide set quality wasn't there. The uniform quality of images, uniform portion was there. And then we can integrate multiple choice questionnaires and tailored quizzes, which can foster autonomous learning. Instantaneous real-time feedback also allows students to evaluate their own performance because the slides are annotated and they can give us instantaneous feedback, which is useful for us also to change the methodology or to change certain things if we find that the feedback is not good, or we can improvise our ideas. And this also promoting self-reflection and self-improvement. This provides students with a unique opportunity to enhance problem-solving skills and augment diagnostic capabilities. So in future, so again, as I say, they should think as doctor because ultimately they are the future physicians. And so this generates interest in their kind of interest and fun learning and lesser burnout. Next, please. Now there is social media has revolutionized the way we share and acquire knowledge, opening new avenues for education and communication. Skillful use of social media platforms enables effortless interchange and borders of knowledge acquisition. So we can share our slide sets, or we can share the links to various digital slides. And this also fosters egalitarianism in education by providing equitable access to information for both students and educators. So here also digital pathology used to be very helpful because we can share various links for students, and we can share various questionnaires and other things linked to that links. And sometimes we can even share the images, and we can enlarge, and all those things are possible by sharing in social media. Next, please. Of course, there are certain challenges with this, but these challenges are, as far as advantages cross are there, the challenges are not that high. Sometimes there is failure of technology. Every institution may not have the similar technology. Sometimes students are unable to manipulate the things. And sometimes, very rarely, faculty are not that trained to incorporate digital pathology with clinical case scenarios and other integrations like radiology and molecular pathology. And next, please. So lack of training on for faculty, the major challenges, lack of training on how to use of technology effectively. And there is resistance to change from traditional teaching methods, limited access to digital pathology resources or equipment. And lastly, it is difficult in creating and managing the digital pathology content, like relevant content woven into the case-based scenarios. For next slide, please. For students, also there were some challenges like limited opportunities for hands-on experience with microscope and glass slides. This was actually highlighted long back, and many institutions highlighted then they cannot not learn microscopy, they cannot handle glass slides. In fact, what I observed that this was not that necessary, not at all needed. They can learn what are the parts of microscope, and when later on during their diagnosis, they are discussing the slides through digitization, it's not at all needed. And then sometimes students face lack of familiarity with digital pathology technology and software. And next, please. Technology also has certain challenges like high cost of the equipment and software, limited compatibility of software with existing systems, and limited standardization of digital pathology technology and data formats. Sometimes there are concerns with security and privacy of patient data stored in digital pathology systems, because we have to have every labs also. We have to have clinical case studies and then with the digital slides corresponding to that particular case. And next, please. So this was all about the digital pathology, and innovation and digital pathology and high resolution imaging is revolutionizing the way we approach education, research, and patient care. The future is bright and limitless. Yeah, you're welcome to ask any questions.
Thank you
Thank
so
you.
much, Dr. for a wonderful talk. Any questions from the audience? I guess no more questions. So thank you for your time.
I have a question.
Sure, Dr. Richard.
I have a question.
Yeah, sure, please.
Dr. Saxena, should I ask?
Yes, please.
Yeah, sure, you're more than welcome.
Dr. Saxena, it was such an eye-opening, excellent talk that I wish I had followed you instead of predecessing you. But tell me, how can we implement this worldwide in the universities and replace? Do you think it will replace the age-old pathology and the pathology books, and soon we shall go only into digital learning pathology?
Thanks for your kind words, and it's much appreciated. As far as the replacement of glass slides with in the medical curriculum, most of the schools we are mostly using images nowadays in most of the schools, even in here in India, as well as in many places. As I said, this is a kind of global this is a global revolution. So most of the time we are using glass slides, and this is particularly evident in the cases where there is system-based learning, because there are a different kind of integration in US and most of the schools. This is called system-based learning, where we are teaching physiology, and after physiology, there's pathology class. After pathology, there's you can say pharmacology, like this. This is system-based kind of, and in short, I explained you. So as a result, unfortunately, pathology classes has not have that much time to have that lengthy a practical, which we in our student life were, we were exposed to so much lengthy practicals. And that there also, ultimately, this glass slides will never work, because and so many microscopes, they have to pull out the microscopes, and then they have to keep back the microscopes, then they have to arrange the glass slides, and then sometimes they don't see the things, because every glass slide is not same. Glass slides are fading, some glass slides are fading, sometimes they are breaking, and it consumes a lot of time. So ultimately, since in system-based learning, the time constraint is there, and there also digital pathology help. And I think ultimately it is going to be a future for in medical curriculum for digital pathology only.
I think both of us can work towards starting digital pathology departments all over the world. I would be very happy to work with you.
Thanks again for your kind words. Yeah, it's interesting. It seems interesting.
It was very excellent, and it has given me a lot of thoughts more. I don't know whether you attended my presentation, but I want to replace invasive biopsy with a non-invasive biopsy. Thank you very much, madam. It was a pleasure listening to you.
It's my pleasure. It's much appreciated. Any other question?
Great. Thank you so much. Thank you so much again, Dr. Saxena, for the wonderful talk. I will introduce our next speaker. Our next speaker is Dr. Anil Pravani. He's our keynote speaker from Ohio State University. Dr. Pravani's title of the talk is Digital Pathology, Nuts and Bolts of Digital Pathology and AI Implementation for Primary Sign-Out at a Major Academic Institution. So I would like to welcome Dr. Pravani.
Thank you so much, Dr. Memon. Thank you. Are you able to see my screen? You're on mute.
Organizers, can you please stop the share so Dr. Pravani is able to share his screen? Yes, we can see it right now.
Okay, excellent. Thank you. Thank you so much for inviting me to speak today. So Dr. Saxena has laid out a really good foundation for digital pathology. So I'm going to focus more on the clinical aspects of digital pathology and AI. And I'm going to share our experiences at our institute, how we went about it, and where are we today. So what have we learned from this process? So this is, on the left-hand side, you can see a picture of the football stadium at Ohio State. It's going to get, football season is going to start in August. You can see 120,000 people cramped in this small stadium waiting to see the football game. And then on the right-hand side is a picture of downtown Columbus. So today I want to give you an overview of digital pathology and AI and its current state for clinical diagnostics. And I'm going to build on some of the things that Dr. Saxena has already covered. But the goal is, are we ready for digital sign-out? And I know Dr. Memon has already started to do that at their institute. And where do I see the future in this? So we have new tools for high-value clinical diagnostics. We have many rapid innovations in pathology today, more variety and complexities of available tests and services. And every day, clinical teams are asking for more and more testing to be done by pathologists, by pathology. There are new molecular tests and testing techniques, more automation, not so much in anatomical pathology, but more in clinical pathology. So I'm going to focus today on digital computational pathology, and AI. So as a pathologist, our reports are becoming more and more complex. And starting from gross pathology to histology to making a diagnosis and providing that important information to the patient's treatment plan is becoming a more and more vital role for pathologists. You know, some people consider pathologists to be a diagnostic service provider, but in my opinion, pathologists are clinicians as well, and they are as much as and even more important as clinicians than we can ever realize before. So if you look at the knowledge, right? So I'm a GU pathologist. I sign out GU every day. Today I have 30 cases to sign out for GU. If you look at the 2016 edition of the GU WHO book, 356 pages. 2022, 590 pages. And there is a lot of information about molecular and genomics that we didn't know about. When I was a resident, all I need to learn was 5 different kidney tumors. But today we have like 100 kidney tumors to learn about. And that list keeps getting longer and longer every day. So the point is, how do we tackle this knowledge? How can digital pathology and AI help us in this explosion of molecular information? So these are some kidney tumors, which are pink, oncocytic. But if you can see it's a wide spectrum from benign to malignant tumors, some very rare tumors we didn't even know about. And probably I misdiagnosed many of these in my earlier days. So we are, as pathologists, very visual, right? We learn visual information. We learn pattern recognition. Remember your first days as a resident? You used to compare this image to this image. You used to open flip books and look for matching entities. And Dr. Saxena talked about that as well. So I love my H&E slide, right? I don't want to give it up. But today, we have the H&E slides digitized. And we can now use the H&E slide and the microscope to create whole slide imaging. So we can now enter the world of computational pathology and AI, because all the information in H&E slide, once it's on the glass slide, it is at the end of its life cycle, right? So the goal is, how can we harness the power of information in that glass slide and make use of it, right? So if you look at the digital pathology subsystems, we can go beyond a camera on a microscope and capture images and create whole slide images. And essentially, there's hardware that needs to be done, robotics, scanning, optics, AI algorithms to detect tissue, acquire the images, view the images, store the images, and do image analysis and AI on these images. So we've come a long way, but people always, pathologists especially, love their microscopes. They don't want to give it up, right? So, but if you look inside the box, inside the scanner, it's your microscope. It's just a different way to approach it. If you look at your glass slide, when it's digital, you have all the information you need in that virtual slide or the whole slide image, but you can do more with that image than you can do with the glass slide, right? So you can, with a glass slide, you can review the image. After 2-3 years, the stains will start to fade. If you're using methods to cover slip it, those cover slips will start to fall off and peel off. So this is an opportunity to preserve your images, your glass slides, and explore new opportunities to find things in this image that you didn't even think was possible, right? So this is where AI comes in. if you look at the state of the whole slide imaging industry, today we are able to load a scanner with 1,000 slides at a time and leave them as a clinical device. And at the output is going to be 1,000 clinical images. You can scan roughly 1.5 by 1.5 centimeter tissue section within 1 to 4 minutes with a resolution which is 0.25 microns per pixel. So what does that mean? It's really, like if you think about the resolution, and I will come back to that, you can also think about how do I get a way to get a 3D perspective on your slides, right? So this is where Z stacking comes in. So when you scan a slide in 2 planes, you will capture some of the information, but not all of the information. But when you start to do Z stacking, you can scan this slide. So if these blue dots are cells, you can scan the slide at 3 different planes. So you're going to see a 3D perspective on these different planes. So if you look at this, if I just scan it in one plane, I will just look at a flat image. But if I scan it in multiple planes, I can see this cluster. And that's very important for cytopathologists, hematopathologists, neuropathologists. And this is the key, right? So as pathologists, as we evaluate these images coming out of scanners, we should give our input to vendors and make sure that they understand that this is very important for certain areas. What about resolution? So I'm a GU pathologist. This is prostate cancer. When I look at this slide and the image from it, I want to be able to see nucleoli. And I want to be able to see 2 nucleoli, 3 nucleoli. And I should be able to resolve them apart. So this is where spatial resolution comes in. What about the patient context, right? So you don't want to just plug a scanner in the wall and start scanning slides. You want to present them to the pathologist in the context of the patient, right? So if you're a hematopathologist, you just don't want to see a scanned lymph node. You want to see the flow. You want to see the patient's demographics. You want to see the patient's prior biopsies. You want to see the peripheral smear. You want to see the bone marrow biopsy. So all this information needs to be presented in the context of the patient. So if you look at anatomical pathology, and when you decide to go digital as a lab, you have to think about all the different parts of this workflow, from gross pathology all the way to images and the integration. We need to create more standardization in pathology workflows. And the moment you decide to go digital, it will impact the quality of your glass slides. It will impact the quality of your workflow. And that's very, very important. So as the factors to consider when you are selecting a whole slide imaging scanner is, what are you going to use it for? Are you a research lab? Are you in public health? Clinical? Are you doing both research and clinical? How many cases are you going to scan? How many slides will you, and the types? Is it going to be just the regular slides, or are you going to do whole mounts? How many people will you need to scan the slides? What is your existing system? And you have to be realistic, right? Some pathologists might not be ready for it. They might say, I love my glass slides. So you have to be realistic and be prepared for some pathologists not going live at the same time. There are a number of different types of imaging devices out there, some which can do whole mounts, some which can do 1 slide at a time, some which can store and scan 1,000 slides at a time. So the good news is, as a consumer, you have a lot of choices today, and you ever did. When I was first starting in this field, there was only one scanner available, right? So today you have hundreds of scanners available. And you also have different types of digital pathology solutions. As Dr. Saxena mentioned, you have cameras on your microscope. You have whole slide scanners. You have robotic microscopes, which can do both scanning and allow you to review images remotely and adjust the focus remotely, and also use AI and image analysis. So there are different solutions, hardware and software, which we didn't have 10 years ago, right? So this field is rapidly evolving. The cost to make an H&E slide digital continues to go down, not just because of labor shortage or labor cost, but also infrastructure cost, right? So when you buy a big screen TV today at Best Buy, you're going to pay a lot more than you paid 10 years ago. And that's because the cost of the chips, the computing power has gone down, continues to go down. And adoption has continued to increase. So again, as a consumer, you have a lot more choices today than ever before. So that's good news for digital pathology. In the United States, we have multiple systems now, which are hardware and software, which are available and have been approved by the FDA for primary diagnosis, starting in 2017, 2019, and then more recently in 2022. So I expect in 2023, there will be several other scanners, hardware, software will be approved for primary diagnosis use and clinical use. But no doubt, this is expensive, right? So when you go to your hospital administrators, you're going to have to justify the cost of the scanners, the servers, the storage. Again, it's going down a lot, the cost of storage, but it's still a cost, right? So unlike radiology, pathology is different. Radiology, when they became digital, they gave up the film. So they save money. Pathology, we still need to make glass slides. So until we get to a point where we can go directly from the tissue to an image, just like radiology, there is going to be an extra cost. But the good news is there are several different technologies on the verge of making their way into clinical space in pathology, which will replace the glass slide. And that's not necessarily a bad thing, because we are facing a shortage of labor, shortage of histotechnologists. So there will be a point where we will have options. In some tissue types, we can go directly from a cell to an image. And those technologies are already making their way. So why should we consider a digital transformation, right? So there are different reasons: increased productivity, improving the quality of your care. As a pathologist, when you show a case, you wanted that process to be seamless and easy. If it was challenging and difficult, you had to ship glass slides, you had to walk over multiple blocks to show this to an expert, or wait for a long time to get a second opinion, you're not going to do this as a pathologist. You're less likely to do it. You have opportunity as a lab to create increased revenue streams, do some cost savings, consolidations, and innovations. And then this is the most exciting part for me, because whatever we did today, which is to go from a digital glass slide to digital and converting into millions of pixels, today we can now have the power to start deciphering those pixels. And that to me is the most exciting part. So in pathology, we have challenges, right? We have lack of standard. So I'm talking mostly about anatomical pathology, lack of standardization. If I pull up a barcode from Toronto, Mackenzie Health, and compare it to Ohio State barcode, they're very different. The slides are very different. We have subjective diagnosis in pathology. We have manual processes in pathology, and we have a shortage of pathologists worldwide. Very few medical students, US medical graduates, are going into pathology. There is an explosion of knowledge, and we're doing, as a pathologist, you're doing a lot of time-consuming tasks. You're counting things, you're measuring things. And when you go home from your daily life as a pathologist, you are doing things more seamlessly, right? You're using AI in your life. You're ordering things online, you're traveling, and you're using your smartphone and AI for all those different tasks. Why can't we use those same tasks at your workplace? Why can't pathology become more automated? And I think that's where digital pathology and AI will help pathology. It's a perfect storm, right? It's a perfect storm for disruption, standardization, more objective diagnosis, more automation, accuracy, and maybe speed. But as what it does offer you today is more time to do other tasks. You know, you went to medical school and became a pathologist to help patients. But oftentimes, on a day-to-day basis, you don't even have any contact with patients. You don't even see daylight. You come to work, you bury yourself in your workload, and you go home often dissatisfied. So how digital pathology can actually help you create a new way to transform your work day. And I can tell you, every day when I come to work, I'm excited about it because I have tools now which make me a better pathologist, which make me a better clinician. And I'm able to keep up with the knowledge. I don't have to count cells anymore. I don't have to count for how many mitoses are in this field of view. Those are things that we can start doing routinely, right? So again, some important questions to ask, right? Does AI really work for you? Are we there yet clinically? Does it make pathologists more accurate? Does it make pathologists faster? Does it save us money as organizations? So again, digitizing pathology is not trivial. So I'm not going to say it just can happen just trivially, but it involves hardware, software. Most important component of it is the people, right? So if you have 3 pathologists in your organization who are not going to sign out digitally, you have to change a lot of workflows. You have to have 2 different workflows. You have to change procedures. But at the end of the day, you want to be able to integrate your lab information system, whole slide imaging, and all the information that you need. So in my office, I have 3 screens. I have all my pathology images. I have all my electronic medical records. And I have a 3rd screen where I do analysis of this information, right? So interfaces are critical in pathology. So interfaces between digital pathology systems, the lab information system, and the EMRs. So at the end, you want to be able to connect any scanner to your systems and use any AI tool. All right, so I'm going to just briefly walk through what we've done at our institute. So we started with static images. We had cameras on microscopes. We started dwelling into robotic microscopes and started using telepathology for frozen's and for second opinions, whole slide imaging for education and integration with lab information system and primary diagnosis. So today we are at this step where we're starting to use deep learning tools and AI. So we have about 85 faculty, AP, CP, molecular, outreach. We have a children's hospital. And so we have several outreach hospitals. And our clinical volume is about 90,000 surgical cases, which translates to about 600,000 plus slides and approximately 3,000 slides a day. So when we decided to go digital in 2017, we were in a lab which was not even connected to a histology lab. Right? So a histology lab was in a different location. But we started going back into the archives and scanning slides for whole slide imaging. We moved to a new lab information system in 2019. And then we started acquiring some other sites which were 100 miles away, 50 miles away, and we started providing services to those hospitals. So this is the hospital which I work in. This is the James Cancer Hospital. And this was the space that we got in 2017. And we installed a few scanners there, and the goal was initially to scan retrospective slides. So this is the scanning center. So we brought in all these slides, which were de-identified. They were linked to the EMRs, barcoded, and then they were available to any pathologist for clinical use. This is a smaller hospital, which is 100 miles away from Columbus, Ohio. This is where we provide frozen section services. So we started buying small scanners for these hospitals where they were connected now virtually to the main campus. And they had access to all the subspecialists. And we started training histotechs to start scanning slides. We started creating opportunities for them to become part of this digital pathology transformation. So this is how our scanners are connected. We scan every slide and store them in duplicate. We store them in 2 different places, 2 different data centers. And as soon as the slide is scanned, it's available to the pathologist for review. So digital pathology has really transformed the tumor boards and interactions with clinical teams, quality assurance. So it's really impacted all the pathology workflows. This is a pathologist who is working remotely, has Epic, Beaker, has the EMS, IMS system. And this is a pathologist of home office. So they have all the different tools they need. This is their work list. So they can see, click on any patient, and they have all the information they need, including slides that were ordered and become available as soon as they were scanned. So this is directly clicking on that and getting the slides. And then this is the IHCs that you order every day. So the scanned slides are instantly available in the image management system. And we can now go directly to individual slides rather than cases. So that's been a big transformation for us. So measurements, annotations, co-registering. So this is a liver biopsy where you have patient with cancer, and we can lock the same view and see the same view on the immunostain simultaneously. So if I go up and down, I can see the entire slide. I can consult with colleagues very easily now. So I can just say, what do you think? And I can see who's online today. If Dr. Mammon is online, I can just click a button and she can review that image, or other colleagues. And we also have a consultation portal now, which allows us to receive consults from anywhere in the world, which makes it very, very exciting for pathologists because they can see all these exciting new cases from all over the world. So this is an example of a consultation portal. So again, images are of diagnostic quality, and we can now offer services that we could not offer at remote places, like an FNA service. So getting a box like this with a microscope inside, pathologists have now an ability to review slides remotely. And again, what's inside the box? It's a microscope. So as a pathologist, you're not giving up your microscope. You are, so these are some examples of workstations around the campus now, where pathologists have access to small slide scanners, which can load 1 slide at a time. And these images are all connected to the image management system. Again, another example of a scanner. So we started in 2017 with one scanner, but now we are up to 25 scanners around the different hospital systems. Small scanners, big scanners, research scanners. In terms of frozen sections, it's really offering a lot of opportunities for trainees, right? So they can train and see these frozens in real time. So I was on call on Monday night and I got a frozen at 1 a.m. And it was a kidney biopsy and a liver biopsy for a transplant patient. So I was able to log in from my home and directly communicate with the resident, teach them. I spent 2 hours during this process, but it's a great opportunity for trainees to learn and preview cases for FNAs, frozen sections. And because all this material is archived, this becomes a, I remember as a resident, I used to get glass slide recuts. No need to do that anymore. It's all digital, it's available. And so we have over 3 million slides scanned since we went live. And pathologists are, in the beginning, were afraid to give up their microscopes. They did not completely trust digital pathology systems. And there was a lot of regulatory hurdles and financial gains were not clearly defined. But that's really changed over the last 3-4 years, especially during COVID. More and more pathologists were remotely working, and that's really impacted their workflows. So for me personally, digital slides have improved my workflow with a direct interface to the LIS, sharing cases with consultants, tumor conferences, education of residents, flagging cases, looking at controls. It's really improved my turnaround time. So I have not slowed down at all. In fact, I have found efficiencies where all these little things that we did every day as a pathologist have really been transformed by this workflows. So there are still issues, right? We still have to, polarization is still not very easy to do, but today there are scanners which can do polarization. I was at the USCAP meeting in New Orleans and I saw a couple of scanners which can now start to do polarization. Z-stacking is there, right? How about teaching residents? What if you were completely digital workflow? Do residents even get trained on microscopes? So those are important things to think about. What about oil for hempath, right? So again, there are new scanners out there which are going to transform hematopathology. And I'm really excited about all these different areas beyond surgical pathology. So we have these archival slides, which are becoming important in tumor boards, resident slide sets, teaching sets, a lot of research opportunities and special requests. So on a daily basis, we are signing out 200 primary diagnosis sign-outs every day without any glass slides. Nearly 80 consult sign-outs without any glass slides. Numerous tumor boards. So we have almost 2 or 3 tumor boards every day, with different subspecialties. And we don't have to share glass slides anymore. 5 people could be working on the same slide and doing research on it. And almost 144 faculty, residents, fellows, and staff are interacting with the systems. So these are now clinical systems. So in conclusions, what are the benefits for the pathology department, right? It's decreasing the time to diagnosis. Your dashboard is really where all the information is coming in. We, as pathologists, what do? We make diagnoses. So anything which can help that make the diagnosis better, faster, and improve your quality of your diagnosis is a good thing. We have a number of algorithms that we are using at our institute, including image analysis and AI. We have algorithms which allow pathologists to screen lymph nodes. and look for metastatic disease. We have algorithms for quantitating HER2/neu. So these algorithms are going to be the game changers for us. Consult instantaneously, not just locally, but globally. So we have now practices where we offer consults in different states, different countries. And pathologists like it because they have access to complex cases and opportunity to provide rapid second reviews. And again, improving the quality of their own personal diagnostics. So with this, I'm going to stop. And again, once you have the slides digital, you can go beyond the glass slide. The glass slides has an end life. You can start to build applications that we're just starting to delve into. So the next 5 years, we will see an explosion of this field like never before. So with this, I'm going to stop, and I know I'm over time. So thank you so much for the opportunity to speak with you today. And if there are any questions, I'll be happy to answer them at this point.
Thank you so much, Dr. Parvani. It was an amazing talk. I'm a big fan of yours. I've learned a lot in digital pathology, and you can consider me one of your students as extremely knowledgeable person that I know in digital pathology is Dr. Parvani. And I'm the real life example from McKinsey Health. And Dr. Parvani has helped us a lot. And we have learned a lot from him and acquired and successfully implemented digital pathology at McKinsey Health, Ontario, Canada. So huge thank you from McKinsey Health and from me and personally.
I wanted to ask him a question.
Go ahead.
Namaste, Dr. Anil Parwani ji. Good evening.
Namaste. Namaste.
I am Dr. Rege from Mumbai. I don't know if you listened to my presentation with which had given a lot of problems, but I loved your presentation just like Dr. Richa Saxena's. And I think artificial intelligence and the developments, the virtual reality is definitely soon. I said in my presentation that soon the microscope, even the glass slides also may need to be replaced. So do you agree we could do it in future? The microscopes will be redundant. As Madam Saxena said, the pathology curriculum will have to undergo a drastic change, and I can see opening universities where the digital pathology has to be taught than the conventional pathology, of course, with the anatomy and the pathology keeping intact. What's your impression about future of pathology? So
I believe that we will reach a point where we don't need to make glass slides, but it's still
exactly.
It's probably a good 15-20 years away for completely digital pathology, where you go from tissue, cells to an image. But it's going to happen in leaps and bounds, and it's already happening in some areas of pathology. So that piece will take some time, and it's going to help us transition into a digital world where some people think in the future there will be no pathology, no radiology. It's all going to be diagnostic medicine. So when you are a resident in pathology, you will join a residency program in diagnostic medicine, and you will take courses which will prepare you for diagnostic medicine. But you will spend 2 or 3 years learning pathology, or 2 or 3 years learning radiology. If you think about all the data that comes from clinical labs, it's almost 70% of the data in the EMR is coming from these different modalities. So I believe in the next 5 years, you're going to see a transformation in how we make a diagnosis as pathologists. And you will have very subspecialized tools for hematopathologists, for molecular pathologists, for soft tissue pathologists, where these will become everyday tests, and they will help guide you to create better decisions on your diagnoses. But that's going to happen in the next 5 years. In the next 10 to 15 years, you're going to see more and more images replacing glass slides. And then with all the things that are happening with medicine and AI, these tools will become a common thing now. They will become commodities. Like your smartphone, right? You have apps on your smartphone. These will just become apps on your monitor. You will start using them every day. So I think it's an exciting time to be a pathologist. I'm not afraid of AI. People always ask me, will it replace you? It's never going to replace me. It's just going to make me a better pathologist.
So just one small question. Do you think the pathology, I want to transform the pathology from invasive to non-invasive. Am I right, or I'm just daydreaming?
So some people think that when you are looking at a polyp with endoscopy, that's gross pathology, right? So there are areas in pathology where you can do that today, but there are boundaries around your discipline today, which will start to become more blurry over time. So yeah, those are possibilities, but it's not clearly defined today.
Thank you very much.
Thank you, Dr. Prabhani. Any more questions from the audience? Amazing, great. Thanks again for your time. So I would like to introduce our next speaker, Dr. Michael Retzky. He's the Associate Professor at the University College London. And so the title of Dr. Retzky's talk is Continued Exploration of the Perioperative Window. Dr. Retzky, you can
see me?
Yeah. No, second. Just
I had video a little while ago. No, I don't have it. Well, can you see my slides? Are any slides being seen?
Yes, we can now.
Okay, I cannot see them, so I don't know what you have. Okay, I can barely see my slides in the background. Okay, this is a discussion that I'm going to present. I am a scientist. I'm a physicist by training, and I made a career change into oncology research. I'm at the University College London, and let's see if I can get.
The organizers, can you show? Okay, Dr. Retzky, you can say next slide. The organizers will be able to go to the next page of your slide.
Okay, next slide. I can't see what's being seen, but okay. I'm sorry, I can't see what you're showing there.
Are you able to share your PowerPoint?
I can see you. I can see. There's a big white area in the middle of my screen that's blocking it. I can see my face now. Okay, I'll have to work with it. Okay, so I can see around it. Next slide, please. Okay, I'm going to be working on a project that's hopefully going to reduce the triple negative breast cancer, and we want to do it in Nigeria. Nigeria has an area where they have a much larger problem with triple negative breast cancer, and it occurred to us that it would be a very good place to do this. I really can't see what you're showing. Okay, now I can see it. All right. Thomas Kuhn published a book in 1962, and this caught a lot of attention in the world of science. He described science as having 4 phases. First, when a new science comes out, it's called the pre-paradigmic phase. and there's no consistency among the researchers. What are the mechanisms, how to do research? And this can go on for a while. And then after a period of time, it gets into normal science. Textbooks are written. People are teaching these classes at the universities. That's fine. And that can go on for a very long time. But once in a while, you run across an anomaly. And Kuhn called this a crisis. Data that show up that are not explainable by the conventional science. Okay, I edited a book that was published in by Springer Nature a couple of years ago, and I happened to catch a picture of it on the front page of the New York Times, so I took a picture of that. Next slide, please. The foreword to this book was written by Robert Weinberg. Robert Weinberg is a well-known oncology scientist at the MIT, Massachusetts Science. What Weinberg said, I'll just discuss two parts of it. He said this is going to be easy, it's not going to be easily accepted by many in the oncology field, and it's likely to profoundly influence future surgical oncology and post-surgical treatment. Next slide. This project has been going on for a long time. It started in 1993. I was attending a cancer conference in Europe, and out in the lobby, a poster was being presented by Romano Demicheli of Milan National Cancer Institute. He described relapse rates in breast cancer as having a bimodal property. There was an early wave of relapses in the first 3-4 years, and then there's a minimum at about 4 years, and it started up again. And this seems to be out of the ordinary. This was not accepted. This was not considered as what has been described as cancer growth. It seems to show that this is something unusual. And then a paper was being presented by surgeon Michael Baum in the lecture hall, and he talked about a bimodal relapse data from UK data. Afterwards, we all got together and decided that Doctors Baum and Demicheli were talking about the same thing. The Demicheli data are by far superior, so I'm going to concentrate on that. There were 1,173 patients with long-term follow-up. This was well before the use of chemotherapy, so this is surgery only, mastectomy only. There was a sharp peak at about 1.5 years and a minimum at about 50 months. And then a broad shallow peak started at 60 or 70 months, extending to 10 years and longer. Next slide, please. I happen to have a very high regard for the Milan data. I've been doing a lot of research in breast cancer, and I have a lot of experience with databases. I have found the Milan data to be the best by far. And the three features about the Milan data that I like are that patients in Milan are known to comply with the directives of the physicians. And the second thing is that people often remain in cities and towns for a long period of time, for generations. So that means that you don't have lost data as patients move around. And the last but not least, Panuccia Valagusa has been a database manager since this project started. She is about the best I've ever seen as a person running a database. Next slide, please. Okay, these are the data from Milan shown in relapse hazard format. The relapse hazard is the probability of a patient undergoing a relapse in a 3-month window if they enter that window relapse-free. So you can see there's a sharp peak at about 18 months and then a minimum about 48 months. And then there's a second shallow peak at 60, 70 months. And that goes on to over 10 years. that information at about 100 months is we don't know what that is. It could be noise or it could be important. But the two peaks that we're going to talk about, that first peak at about 18 months and that second peak at about 60, 70 months. Next slide, please. Okay, what I showed you before was for the postmenopausal patients. For premenopausal patients, that first peak seems to have two peaks in it. There's a peak at about 10 months and a second peak at around 30 months. And you still see that second, the shallow peak at 60 months going out to 10 years and more. These were anomalous data. This was something that was not expected. Next slide. This is another figure from published in the New England Journal by Bonadonna and Valagusa. Bonadonna was the first person, he's dead now. He was the first person to use multiple drugs and adjuvant chemotherapy in breast cancer, a very well-known person in the name in the world of breast cancer. And Valagusa was a co-author. What you can see here, this is relapse, probability of relapse. So it starts off that everyone is disease-free by definition, and then there's a sharp drop off, and it seems to reach a plateau at about 5 years, and then it starts up again going down to 20 years. This was unexpected. I mentioned that I have a background in physics, and this is the sort of shape that I would see if I was looking at radioactive levels from a compound consisting of two radioactive sources. One has a high, has a short half-life, the other one has a long half-life. So what you see here is that there's an early drop off, and it seems to reach a plateau at about 5 years, and then it starts up again. This looks like what I saw when I was doing research of radiation. It looks like there are two different groups of relapses in the Milan data, and that I'm saying reminds me that this looks like two different distinct groups of relapses folded upon each other, with one as a half-life that's much shorter than the other. Next slide. This, in general, was not explainable with what has been called a continuous growth model. This has guided breast cancer early detection and therapy for a long time. Next slide. Demet Kelly and I decided to collaborate. He has an MD, PhD. He did a lot of work with studying cell growth. He published a number of papers discussing cell growth. He said the simplest way he can describe cell growth is it starts off as a single cell that can remain in a dormant state until it starts to divide. And once it starts to divide, it can get up to about 1 million cells or a 1 millimeter diameter tumor, and nothing else can go on until it gets angiogenesis, until it gets a blood supply from the host. So it's another possible dormancy period. And then once it gets angiogenesis, it can grow to a detectable size and a lethal size tumor. Okay, so my strategy in this project was, my field is in physics. I've done a lot of work with computer simulation in breast cancer, and the strategy of this research was that I was going to take the Milan database, the Bonadonna-Valagusa database, and Demet Kelly's model, and try and understand what those various peaks represented. Next slide, please. Okay, this is the interpretation from the computer simulation. I'll show you more details later, but that first peak at about 10 months, these are surgery-induced angiogenesis. These are little micro deposits that were sitting in a dormant state without angiogenesis and just waiting for the blood supply to occur. But it looks like the surgery induces angiogenesis, And these avascular micrometastases showed up as relapses at about 10 months. That 30-month peak was single dormant cancer cells that were sitting there at a quiet place, and surgery came along and kicked them into division, and they started to grow, and they became metastases at about 30 months. You still see that minimum at about 50 months, and that long shallow peak at 60, 70 months, going out to 10 or more years. Next slide. Okay, just general comment. Computer simulation, as I've done it, it's a very powerful tool, but it's only as good as the clinical data that we have to look at. I can do the computer simulation, but I need to have clinical data to understand what's going on. Also, my co-authors in this research are medical specialists from a variety of fields: anesthesiology, medical oncology, surgery, and one person is a blood supply person. This research crosses several clinical boundaries, so having these multiple specialists on as co-authors is really important. I mean, I can do the computer simulation, but I need these co-authors to keep me from getting into areas that don't make sense from the cancer perspective. Next slide. Okay, the results of the computer simulation, I can tell you the quantitative results. That 10-month peak, those were avascular micromets that were induced into angiogenesis. This occurs in about 20% of premenopausal node-positive patients, and it was sharp, and it was 5-to-1 node-positive to node-negative, and 2-to-1 premenopausal compared to postmenopausal. So there's a particular group that seems to show that 10-month peak. The 30-month peak, these were previously inactive single cells, and they were induced into division, and then they vascularized stochastically, showing up as a metastasis. And surprisingly, 50 to 80% of relapses are iatrogenic. They are initiated by treatment, and they show up as relapses at 10 and 30 months. And those peaks increase with tumor size and the number of axillary nodes positive. Published this on a number of papers, 1990, 97, 2001, 97, I said that, and 2000. Everything is available online. You can see it on the internet. And there's one that discusses the late relapses. That's also in year 2020. Everything is available online. Next slide, please. I was a visiting professor in 1989 at the University of Texas. I was doing work with Bill McGuire. McGuire was the person who first came up with the idea that hormones are a prognostic factor in breast cancer. And he knew I was doing computer simulation. He wanted me to add the hormone values onto the computer simulation. Well, I got into trouble, and I ended up spending 2 months just doing literature research. I ran across this paper. This was a very unusual paper. This was done in the time of where physicians would not operate on a patient right away. They could do watchful waiting for months, even for active tumors. This is a case of a 16-year-old boy who was diagnosed with osteosarcoma. Smithers was the scientist, the radiologist who did this. This was published in 1968 by Smithers, and I published this again in a paper, Medical Hypotheses, in 1990, where I'm the first author. What's going on in this figure? First of all, the physician he knew that osteoporosis, osteogenic sarcoma typically relapses to the lung. So he was taking x-rays of the lung before he did anything. For 4 or 5 months, he did nothing but take x-rays of the lungs, and nothing happened until he got to a point where you can see that says, just started, just normally can see it, just visible. And then the tumor grew on a straight line on this semi-log scale. That's normal for tumor growth. And he removed the tumor at about 12 cubic centimeters. It was a normal looking tumor. But the really curious thing about this figure was that it seems like they first saw the metastasis just when they amputated the leg. And I've stared at this figure for hours trying to understand what it's telling us. Is that a coincidence that the amputation occurred at the time when the physician, Dr. Smithers, was able to see that metastasis in the lung? Or did the amputation cause it? Can't tell for sure. But I was reluctant to accept the coincidence. I think it would be a very unusual coincidence that the amputation just happened at the time when they could first see that tumor after not seeing anything for 5 months. Okay, so I came to the conclusion, you may not agree with me, but I came to the conclusion that this says that surgery can cause a metastasis to start, can cause a dormant cancer cells to kick off in the lung. But the thing is, it doesn't say how often this happens. Does this happen 1% of the time or 99% of the time? Can't tell from this figure. This figure just suggests that, yes, amputation or a surgical operation can cause a growth of cancer that was sitting dormant. Next slide, please. Okay, I just mentioned this. This Smithers data suggests that surgery can cause a relapse, but it does not tell you exactly when, how often it happens. Does it happen 1% or 99% of the time? However, there was some data that I have to show you in the next figure, Fisher 1984. Based on these Fisher data, we can make some estimates. Next slide, please. This was a paper published by Bernie Fisher in 1984. He died at age 101 a couple years ago. He was a very well-known person in the world of breast cancer. He was the first person to propose breast conserving surgery. At any rate, these data from Fisher show something very similar to what we saw in the other paper, the paper from Demicheli. Look at the top curve. This is a figure for relapses for patients who had 0 nodes. And it says that just simply removing the primary tumor cures 80% of the patients. Of the 20% that relapse, 10 of them relapse in that first 5-year period. And then there's a period with few relapses. And then it starts up again with a slow, long, slow decay down to the point at 10 years and 15 years where you get 20% of the patients have relapsed. But there's 2 phases. And the first phase looks like what we saw in the Demicheli data. Let's look down at the figures at the bottom. These are growth by nodes positive. The figure on top is for 0 nodes positive. The 2 on the bottom are for 7 to 12 nodes positive. And the one on the very bottom is for 13 and more nodes positive. And what I see here is that seems to have that same relapse in the first 3 years from 0 nodes where you get about 10% relapse. And if you go down to the 13 plus nodes, you get about 85% of the patients relapse in that first 3-year period. And something is going on. This looks like something happens between 0 nodes and 13 and more nodes, but the magnitude changes a lot. This is something very interesting. So I came to the conclusion that I could come up with an estimate of how often this happens. For 0 node populations, it looks like it happens 10% of the time. And for many nodes positive, it happens 80% of the time. This explains a lot to me of why mammography works well. Mammography is meant to find patients with 0 nodes positive. And you can see that if they have a surgery nodes positive, surgery causes a 10% relapse. Well, that's small compared to what will happen with a patient with 17 nodes, 13 nodes positive. You have 80% of the patients relapse. So they do their best to find patients with 0 nodes positive. This explains to me what is the value of early detection. You want to find patients with 0 nodes, and this figure from Fisher explains why. Next slide, please. Okay, I've studied a lot of papers in the literature, and you can find that same bimodal relapse pattern in other cancers. I can say I've looked at a lot of cancers. There's no cancer that does not show this bimodal relapse pattern. And my eyes are trained. I can see that bimodal relapse pattern where someone who hasn't studied this for a long time, it would just look like a normal growth rate. But I can see this. Pancreatic cancer, melanoma, lung cancer, prostate, on and on. Every cancer seems to show some pattern. The magnitudes may be different, but there seems to be this bimodal relapse pattern in all the cancers. Next slide. I happen to be looking at a paper, a book. There's one chapter in this book, Irving Ariel, A Historical Review of Breast Cancer Treatment. It was published in that book, Breast Cancer Controversies and Management by Houston. I was fascinated by this one chapter in that book. The author, Irving Ariel, looked at the writings from Celsus and Galen, scientists and physicians of 2,000 years ago. And this is what they said. Well, this has been translated through several languages, so the wording may not be exact, but this is a general what they say. Celsus said, first there's the cacoethes. Cacoethes is a term that's not used anymore, but 100 years ago, that was a small but obvious tumor. So Celsus said, first there's a cacoethes and carcinoma without ulceration, then the fungating ulcer. None can be removed but the cacoethes, the rest are irritated by every method of cure. The more violent the operation, the more angry they grow. After excision, it recurs, bringing with it the cause of death. However, if they do no extirpation, the patient will live longer. So that's what Celsus said. Galen of Pergamon. They have often cured this disease in early stages, but after it has grown to a noticeable size, no one has cured it with surgery. Well, this was strange. This sounds like what we're talking about back there, but the numbers are different. It looks like they were able to actually cure patients without access to pain control or infection control. That was quite remarkable. Next slide. Okay, asking the question, can this explain these clinical observations in breast cancer? First, two items that we looked at papers that described clinical data and wanted to see if this explains what we're seeing in the other data I showed you. First of all, adjuvant chemotherapy works particularly better for premenopausal node-positive patients compared to the postmenopausal or the node-negative patients. And the paper was published. I was first author, and co-author is our Bonadonna, who spent 30 years studying breast cancer growth. He developed cancer therapies. And Judah Folkman, I was on Folkman's staff at the time, and Folkman can accept the fact that surgery can cause angiogenesis. And this could explain, this could be consistent with the information I was showing you before. And there's another thing that could possibly be a correlation. Mammography seems to work better for women aged 50 to 59 than those in their 40s. And I was in Folkman's lab as I mentioned, and there was a meeting. He had his Friday morning meetings, and I happened to have a casual discussion with a person from the Wall Street Journal. Amy Marcus is a reporter from the Wall Street Journal. She is a well-known writer. Typically, Judah Folkman did not like writers from newspapers, but he happened to know Amy Marcus, so she was invited to attend this lab meeting. At any rate, I happened to have a conversation with Amy Marcus, and she asked me what I'm working on. I said, well, I have a paper coming out in about a week that describes why we think early detection does not work as well for women premenopausal compared to postmenopausal. And we attribute it to the fact that surgery can cause tumor growth, and it can accelerate the relapse. So Amy Marcus decided to write a report in the Wall Street Journal describing this. She was a premenopausal patient and a premenopausal person, and her editor was also a premenopausal female. And they were fascinated by the idea that surgery can cause a metastasis, and that could explain why mammography doesn't work as well for premenopausal as it does for postmenopausal women. So what happened? A paper in one of the Wall Street Journal reports in September 2005, a 1,600-word document was published by Amy Marcus. There was a lot of attention, as you might expect. There was a letter to the editor from Isaac Gukas. This is one of the important results. Isaac Gukas was a surgeon working in UK, but he was originally from Nigeria. He said what we described in this paper could explain what happens in Nigeria. In Nigeria, when a patient feels a lump in her breast, they don't go to see a surgeon. Instead, they know that the surgery will provoke the cancer, so they go to an herbalist and get a soothing ointment, where they go back to their village where they die of untreated breast cancer. So this letter from Isaac Gukas fascinated us. Next slide. Skipping ahead to June 2010, a paper was published by an anesthesiologist from Brussels, Patrice Forget. This was at a teaching hospital in Brussels, so they have to expose the residents to all the drugs used in anesthesia. But they decided to do a clinical trial, a retrospective trial, just looking at if there are any differences on what drug was given that anesthesia. Does that make any difference in the outcome? And they found out that one, it was ketorolac, it was an NSAID. There are 3 NSAIDs that can be given as IV in surgery, but ketorolac was the only one they had at the time at that hospital. And this is in Brussels. So they found out that ketorolac, given as a pain control procedure, had a far fewer relapses in the first 2-3 year period compared to all the other groups that were not ketorolac. They published a paper in 2010 Forget was the first author, and it was published in Anesthesia and Analgesia, 2010. Next slide, please. Next slide, please. Could someone please advance by one more slide, please? There we go, thank you. Demikelly and I went out to Brussels and we gave talks and we looked at their data. Their data looked very good. Demikelly has a good background in oncology, and he could recognize clear data from not clear data. This made a lot of sense to him. He did a, no, go back one slide. Go back one slide. I'm sorry, here we go. Okay, hold it there. Demikelly looked at these data and they grouped the patients by whether they were treated with a ketorolac or with anything else. And there was a 5-fold relapse reduction in months 9 to 18 with ketorolac. There were 316 patients and there were 3 versus 15 events in that 9 to 18 month period. Something is going on, something that is involved with the ketorolac that seemed to prevent those early relapses by a factor of 5. Next slide, please. Okay, at this point, we knew that some intervention at or around the time of surgery would be needed to stop the relapses, but what was the mechanism? What could explain these Milan data, the Forget data, sorry. We did a survey and we looked at some very large subjects, but we were looking for correlations between surgery, inflammation, angiogenesis, circulating tumor cells, the immune system, cancer dormancy, and neutrophils. It turns out that there is inflammation. IL-6 is elevated for 1 week after surgery. IL-6 is a marker for inflammation. Angiogenesis platelets decompose in the presence of inflammation, and platelet count dropped by a factor of 10 for about a week after the surgery, and VEGF went up equivalently, and VEGF is what causes metastasis, causes angiogenesis. There are circulating tumor cells, that's well known. The immune system is compromised after surgery, and cancer dormancy might play a role. And neutrophils are stimulated in large numbers from surgery. Okay, I'm going to tell you some of the findings I came up with. Here's a paper from Hiller et al. The perioperative period can be considered a perfect storm of immunosuppression and inflammation in the presence of residual or circulating tumor cells. That was pretty interesting. Another paper from Balkwell et al. Inflammation is not the spark that causes genetic damage, but it's the fuel that feeds the flame. It also seems to make sense. And Agawa published Nature Science Reports, 2013. Capillary permeability increases 40-fold in the presence of inflammation. So something is going on here with the surgery causing things that happen in the body that might correlate with the information we've been finding. Next slide, please. Okay, possible mechanisms. We came up with several possible mechanisms. Neutrophils respond to inflammation signals, and they sometimes form a neutrophil extracellular trap, nets, they call them. These are little webs that are expelled by the neutrophil, and they have the ability to enhance metastasis because they can bind circulating tumor cells and they have the ability to extravasate into distant organs. And then that plus the excess leakage that I mentioned from the other paper. Yeah, this was chapter 4 in that Springer Nature book. After reading that chapter 4 in that Springer Nature book, we would be surprised if surgery did not cause metastasis to appear after surgery. Next slide. This was a paper that was written by someone from Bob Weinberg's lab. Jordan Krell was the first author. They made a mouse model where they can inject cancer cells into this mouse. And if the immune system was intact, these cancer cells would go into dormant states. If the immune system was not intact, that would not happen. But they could do an experiment. They were able to operate on the mouse at one side and get tumor growth on the other side. It looks like the surgery done any part of the mouse could cause a relapse in a different part of the mouse. This was published in Science Translational Medicine, 2018. And this was reviewed by Komaroff in the New England Journal in the June of 2018. And this is what Komaroff said. Corral et al. Paper reviewed by Komaroff in New England Journal, June 14th, 2018. Clinical lore says that resection of a primary tumor can cause previously inapparent metastatic deposits to flare. Well, this is interesting. It says that sometimes something called clinical lore seems to agree with what we found in these data. Next slide, please. This was chapter 8 in that Springer Nature book, Marie-Louise Bondelike-Berntz. My wife and I visited her in Denmark a few years ago. They were working with a zebrafish model. Zebrafish is semi-transparent, and they could inject, they can cause a wounding in this zebrafish, and they can color code neutrophils, and they can watch that neutrophils that are directed to sites of wounding. I mean, that's what neutrophils do. Their function is to repair a wound, but then they are diverted to pre-neoplastic cells that start to divide. So this could be another mechanism by which surgery can cause these metastases. Next slide. This was a paper from a group from MIT. I happen to know 3 or 4 of these people. This is a very high level group. Deepak Panigrahi is the first author, and Vikas Sukhatme is the last author. He was the leader of this group. He was co-author of one of the papers I wrote. He was very helpful. He is now Dean of Medicine at Emory University in Boston, and not in Boston, in Georgia, I guess it is. And the first sentence in their paper, cancer treatment is a double-edged sword. Surgery, chemotherapy, and radiation can induce tumor dormancy escape and metastatic outgrowth, and inflammation plays a role. Okay, this is a very high-level group, and this is their first sentence, but this certainly means a lot to me. Next slide, please. Okay, conclusions. We're talking about an unsolved 2,000-year-old problem in oncology. The early relapses in breast cancer, which are the majority of relapses, they consist of surges of angiogenesis and single cell activation that are triggered by primary surgery that causes inflammation that lasts about a week. The inflammation causes cancer cells and deposits to exit dormancy, resulting in relapses in the first 3-year period by a possible number of several mechanisms. Second one, these data suggest that systemic inflammation precipitates angiogenesis and single cell activity from dormancy. The Forget data suggests that a perioperative ketorolac reduces the early relapses by a factor of 5-fold. This may reduce mortality in breast cancer by 25 to 50% at low cost and toxicity. This is a $2 intervention, and toxicity is low. Breast cancer runs its course in over a decade, but most of the events that lead to relapse seem to occur in that week after surgery. That was a pretty remarkable finding. This suggests that metastatic progression is amplified 100-fold during the week post-surgical, post-primary surgery. Next slide. Conclusions, the surgeon and anesthesiologist should take extra precautions to reduce inflammation. That seems to be what causes these relapses. There are a large number of recent studies for a wide variety of cancers that correlate pre-op NLR, neutrophil to lymphocyte ratio, is a simple but imperfect marker for inflammation. So what they can do is they can take patients who've been treated 10 years ago and go look into the case, into the data on this patient, and they could look at the neutrophil to lymphocyte ratio so they can tell what the pre-surgical inflammation level was. And it turned out that there was a lot of papers, I'm talking about maybe 50 papers, all looking at different cancers. They show that the preoperative neutrophil to lymphocyte ratio is a very important marker for outcome. That high inflammation causes poor outcome, and low inflammation causes a superior outcome. And there's about a 50% difference between the low and the high outcome. Reducing the perioperative inflammation will increase the benefit of early detection. Number 9, our current interests, we want to resolve the unmet need in Nigeria and other countries. And I want to teach this technology to young scientists. I also want to study other cancers. We learned a lot about breast cancer. We have not done anywhere near this kind of level in breast, pancreatic, all the other cancers. So they need to be studied. And surgery apparently causes dormant cancer to wake up. Is that good news or bad news? Well, I'm a cancer survivor. I'm a 30-year survivor of stage 3C colon cancer. And I think this is excellent news. This means there's a possibility of a low-cost and non-toxic therapy. That makes a lot of sense to me as a cancer survivor. Recent cancer data support our findings for many cancers. And as I mentioned with that work with the neutrophil to lymphocyte ratio, breast, lung, osteosarcoma, and many other cancers. Next slide, please. We want to focus in on triple negative breast cancer. I'm sure everyone knows about it. They do not have any of the markers that indicates that targeted therapy will be helpful. The only therapy that works at all for triple negative breast cancer is chemotherapy, which has a small benefit. And I saw one paper that called triple negative breast cancer as the kiss of death. And in the US, the incidence of triple negative breast cancer is 12%, but it causes 20% of the mortality of breast cancer. In Nigeria, it's far larger. The incidence of triple negative breast cancer is in the 30 to 50% range. And the 5-year survival of triple negative breast cancer in the US is low, 8 to 16%, whereas for stage 2 US patients, survival is at 5 years is 93%. Something really needs to be done to triple negative breast cancer, and that's what we want to focus. Next slide. Is there another slide? Yeah, we propose that this perioperative NSAID ketorolac will be an effective therapy for triple negative breast cancer. Evidence looks strong. We intend to test this in a clinical trial in Nigeria. And our procedure will be as described in a paper, a 2020 paper called Black Swan is the title. Osaro Erhabor, he is one of our co-authors. He is a Nigerian resident. He is a PhD, he is a professor of blood transfusion, and he has identified 3 hospitals in Nigeria where they could do this trial. Okay, I'm going to just quit here. Well, just the last sentence here. Our Kuhnian exploration of anomalous data takes us to Nigeria, where we will determine if we are right or if the National Cancer Institute is right. Next slide, please. That's probably it. Now, there's a lot of criticism. People don't like the fact that surgery can cause cancer to spread. This is not welcome news to a lot of people, and NIH has been calling this a myth that surgery causes cancer to spread. Next slide. Papers that are available, the Forget paper in 2010. I published a paper in 2000 well, I was first author of this 2020 paper, and there's another 2020 paper talks about the late relapses. And these 2 links describe, I'm a cancer survivor. The first one discusses that, and that second one describes how I made a career change into cancer research. Okay, thank you. Be happy to take questions. And turn this.
Thank you.
These are my co-authors. These are my co-authors. We can skip that. Okay, you ran out of time. I'll be happy to answer questions.
Thank you, Dr. Retsky, for the wonderful talk. Are there any questions from the audience?
I can be reached by email, michael.retsky@gmail.com.
Thank you so much, Dr. Retsky. You can type in your email for us, and also our attendees will be able to see that. And if there are any questions, they'll be able to email you later on. If nothing is, if there are no questions at the moment. Great, thank you again. So we'll move on to our next speaker.
Hello.
We'll move on.
Can you see my screen?
Let me announce it. Okay, so we'll move on to our next speaker. Yes, Dr. Idrisi Mahdi. He is okay. So Dr. Idrisi Mahdi is from UAE, and the title of the talk is Medical Renal Disease. Welcome, Dr.
No,
Idrisi.
that's not the title. I think there's a mistake.
Sure.
I'm
Okay. Left-sided cancers versus
exactly.
right-sided cancer. Is it the same cancer?
Yes, that's the exact time.
And you are the speaker from that now.
Thank you. Good morning to everyone. It was very interesting to listen to the previous speakers. Allow me to present myself. My name is Dr. Idrisi. I'm a general surgeon in the Department of General Surgery in the University Hospital Hassan II Fez in Morocco, North Africa. I'm here to address a subject that has caught the eyes of a lot of surgeons and physicians for the past decade or more, which is colon cancer. And I just learned that Dr. Retsky was a colon cancer survivor, so that I think that's a talk that could interest him. For a long time, colon cancer has been discussed as one single entity, and even the guidelines have always talked about colon cancer as just one cancer. However, through the years of practice, we noticed, and also other authors from literature noticed, that the 2 locations of the cancer have different patterns and different clinical characteristics. So the question arose, should we still really consider left and right colon cancer as the same cancer? So in order to talk about this, I'm going to talk about a study that we conducted in our hospital. This is an abstract presentation about it. So I'm going to, first of all, introduce the problem and follow a very basic, simple plan and that you could see on screen. So first of all, we have to know that colon cancer is one of the most frequent colon cancers in the world. It's one of the main causes of cancer-related deaths. Of course, it includes all malignant tumors that develop in the portions of the large intestine that goes from the ileocecal valve and to the sigmoid colon. In high-income countries, it has a very important incidence, and even in low-income countries, it's starting to arise. So, which makes it a major public health problem. In Morocco, which is the country where I'm from, according to a study that we conducted at the National Institute of Oncology in Rabat in 2007, colon cancer represents and occupies the first place amongst digestive cancers in Morocco, around roughly 40%. And according to the cancer registry in Fez, which is the city where I'm from, it represents 8% of all cancers in general, and accordingly 38% of digestive cancers. So it is really a very frequent cancer. So, of course, anatomically, we can subdivide colon cancers into two groups. The right-sided, what we call proximal colon cancers, and distal colon cancers, according to the location of the tumor. And these two sides have a very important impact, as these cancers have different embryological, epidemiological, pathological, and genetic characteristics. So this distinction leads us to differences in the disease's evolution and prognosis. And this has been demonstrated in many studies before us. So it's common knowledge. However, it still does not make its way into the guidelines. So consequently, it seems reasonable that colon cancer should start to be evaluated in two distinct categories. However, to this day, colon cancer continues to be managed as a single entity. We're not saying this is a mistake. We're just saying that we need to evolve in cancer therapy and colon cancer therapy, and that perhaps identifying these epidemiological factors, clinical and pathological characteristics, as well as therapeutic modalities can influence the perioperative and prognosis outcomes in patients. So it could lead us to deal with this cancer as two types of cancer to provide a better outcome and better care. So next, we're going to see where this difference comes from. So we say that they are different, but we have to know and understand that these colons do not come from the same origin. They have two different origins, and it goes back to embryology, really, from the start. So you can see here, we are, of course, getting interested in the origin of the digestive system. So we know the digestive system arises from the primitive gut during the delimitation stage of embryonic development, which occurs around the 4th week. It comprises of 3 different parts, as you can see here: the foregut, the midgut, and the hindgut. We're going to be interested in the midgut and the hindgut as the origins of the colon. So the foregut is the origin of the esophagus, the stomach, the liver, the pancreas. But what interests us is the midgut and the hindgut. So the midgut creates the distal duodenum. It creates also the jejunum, the ileum, the cecum, and the ascending colon, and two-thirds of the transverse colon. And it is supplied with the superior mesenteric artery, which continues, of course, into the adult human body, as these organs continue to be supplied by the superior artery. Around 10 to 12 weeks in embryology to the abdominal cavity, and rotates against around the superior mesenteric artery, cecum, colon, and two-thirds of transverse colon. As for the hindgut, it developed simultaneously in close association with the urogenital system, and is supplied by another artery, which is the inferior mesenteric artery. And it continues, as I said, for the midgut to supply these organs even in adult human body. So this difference in origin, it's in a dual vascular supplies. That's dual vascular supply, and it constitutes the basis for all current hypotheses aimed at dividing colonic cancers into two distinct units. So as you could see from the get-go, these two organs, I may say so, do not emerge from the same source. And then it gives us, it makes us think that perhaps they are not the same thing. And as they're not supplied the same vascular entities, and they do evolve quite differently. So this was the premise of our study, that there is a difference between these two columns, and literature have talked about this difference as well and have demonstrated quite a bit of it. So I'm going to go straight to the study that we conducted and the material used and the methods that has been used. So we conducted a retrospective cohort study in our university hospital. We have two departments of general surgery, A and B. So we collided the patients of those two departments over a period of 8 years from January 2012 to December 2020. And initially, we recruited all patients diagnosed with colon cancer, regardless of the location. And they totaled in almost 350 patients in the two departments. And then we installed a few criteria in order to guide our study. So we included all patients with symptomatic or complicated colon cancer, whether they were admitted by consult, appointment, or through the emergency department. And then from those patients, we excluded the following cases. We excluded the tumors with mid-transverse location, appendicular locations, as they were different, and patients with synchronous tumors or double locations, and also patients who we found out to be eligible for immediate palliative treatment where surgery was not in order. I might add that we did not exclude hereditary forms or patients with family history of cancer, which could be one of the limits perhaps, but at that point we did not deem it right to exclude them. So for the statistical analysis, we coded our data and in an Excel file. After validation, we used the statistical analysis software, which was EpiInfo, and we conducted our analysis in 3 steps. The first step, of course, was a descriptive analysis for the data, which was presented in percentages and means. And the second step involved a univariate analysis, allowing for comparison of these means and percentages using statistical tests such as chi-square and studency. The third step involved a multivariate analysis using the stepwise logistic regression, and the aim of it was to identify prognostic factors. These results were reported in the form of graphs and tables, and as per usual, a p-value less than 0.05 was considered to be statistically significant. Some definitions also are important, in order to understand what we did next, because we had to study the prognosis and survival, so we had to set a few definitions for our study. So the start of follow-up for us was considered the date of the first histopathological result confirming a positive lung cancer. So that was the date of follow-up, that was the diagnosis date. The date of recurrence was defined as the day of the relapse, whether it was diagnosed radiologically or by a second biopsy or by the progression of the disease. And the date of loss to follow-up, which is important for outcome, was considered to be the last day the patient was seen in consult, failing that the last imaging performed as part of the follow-up. Overall survival was defined as the time between the diagnosis of colon cancer and the occurrence of the event of death, regardless of the cause, and survival without recurrence or disease-free survival was calculated from the date of end of treatment, whether it was surgery alone or surgery with adjuvant treatment, and the date of recurrence. So survival was studied in 2 parts, as I said, overall 5-year survival and 5-year disease-free survival. And it was calculated using the Kaplan-Meier method. The survival curves were compared using the log rank test, and the significant level was set at 5%. It's important to detail the methodology for people who want to reproduce the study, or if they want to check our data they're available upon a request. So after that, I'm going to talk about the major results we found and whether or not they were comparable to what we found in literature. And to summarize our sample size, as I said earlier, we had 350 patients at first, but we only kept 277 as we installed exclusion criteria and some files were missing. And from these 277, we divide our sample into two groups, a group of left colon cancer and a group of right colon cancer. So the RCC group, right colon cancer, comprised of 99 patients, and the LCC group comprised of 178 patients. And you can see here the patient selection process, which is quite basic, nothing major. So we started with 350, excluded 73 from missing file, exclusion criteria, and we ended up with two groups that are numerically comparable and statistically comparable. So the average age of our series was 57 years of age, with extremes ranging from 19 to 89. And the average age in the right colon cancer was 55, a bit younger than the age in the left colon cancer, which was 58, but quite comparable. And the male gender had a predominance with a sex ratio of 1.3 in both groups. So earlier studies have found that patients with right colon cancer tend to be older and female. We did not conclude to that. However, what we noticed is that the age of our series was quite younger than those we found in European series and in American series as well, and Asian series. I should note that not many studies of the subject have been done in Africa, in the African continent. So we did find a few studies that talked about colon cancer. Age of our series was comparable to those of other North African countries, and this age disparity of the Maghreb region can mainly be attributed, I guess, to environmental and dietary factors, but also reflects the natural distribution of the age pyramid in these countries. 10 of our patients had at least one first-degree parent diagnosed with colon cancer. As I said, we did not exclude patients with family history of cancer or hereditary forms of cancer. So 7 of those belong to the group of left colon cancer and 3 to the right colon cancer, and a history of HNPCC, which is a hereditary non-polyposis colorectal cancer syndrome, was found in 3 patients, 2 from the left colon cancer group and 1 in the right colon cancer group. So family forms and genetic forms were more frequent in the left colon cancer. However, they were not statistically significant, as you can see. Next, we're going to talk about major complications. Right and left colectomies, surgically speaking, as a surgeon, they differ technically in many ways. It's not the same surgery, and their peri and post-operative outcomes are not the same, and they have not been the subject of many analysis. So major complications included for us anastomotic leaks and peritonitis, post-operative peritonitis, which was the most important complications. Only 15 patients required surgical reintervention, 4 of whom belong to the left colon cancer group, and 11 belong into the right colon cancer group. So we did find a high rate of major complications in right colon cancer group, although it was not statistically significant, but it was quite surprising because it goes against the common belief that the right colectomy is an easier procedure, safer to perform, and accompanied with less morbidity than left colon cancer surgery. So that was quite a surprise to us, and that's something that we have to look into. Perhaps it's specific to our center, but we need to look into that. As for anastomotic leakage, we noted a statistically significant difference between the 2 groups. with more leakage after right colectomy. Also a surprise to us. We did a measurement of tumor markers for 88% of our patients. We did the carcinoembryonic antigen and CI19.9 antigen. They were both elevated in the left colon cancer group compared to the right. And among the patients in the left colon cancer group, LCC group, 65% showed lymph node involvement on the CT scan. That's prior to the surgery. We're not talking about the pathology yet. And versus only 34% of patients in the right colon cancer group. So we considered recurrence, as I explained earlier in the definitions, as the reappearance of the disease at the local level, such as the anastomotic anastomosis, another colonic segment, or also as the appearance of a secondary lesion distant, like a metastasis or peritoneal location as a carcinomatosis. So the recurrence rate was quite comparable. So we had 22% for the right-sided colon cancer compared to 24.9% in the left-sided colon cancer. As for overall survival, our results were quite similar to most of the studies. The median overall survival was estimated at 110 months for the right colon cancer group and 100 months for the left colon cancer group. The 5-year overall survival estimated respectively at 87% for the RCC, which was worse than the LCC group, which had a 5-year overall survival at 96.5%. This difference joins what we found in European series, in American series, and it confirms that right colon cancer have a more pejorative prognosis, probably due to the different factors, as they often are locally advanced with significant lymph node involvement and poorly differentiated tumors. So here you can see a Kaplan-Meier curve presenting the overall survival, a comparison between the two groups. It is important here to highlight that one of the main limits of and limitations of our study is the lack of a complete follow-up data for almost 35% of our patients, which is quite a big number. And this factor could negatively impact the results that we found regarding outcome. However, statistically speaking, we found the same results as most series that are available in literature. As for survival without recurrence, the median survival without events was estimated at 52 months, sorry, with a 95% confidence interval. And the 3-month survival without recurrence rate was almost identical for both groups. So statistically, the recurrence rate was 31% for the right-sided colon group and almost 30.9%, almost the same for the group of left colon side group. Here, I don't know if you can see clearly, I'm going to make it bigger. You can see a summary of the demographic and backgrounds and CT findings of our patients. The age of both groups was quite comparable, and statistically, the difference was not significant. We had the same sex ratio for the two groups. As for risk factors, as I said earlier, left colon cancer had more patients with risk factors as a familial adenomatosis polyposis, chronic inflammatory bowel diseases. We had more patients with those in the left colon cancer than the right colon cancer. We had more patients with family history of cancer, 9 against 4. However, statistically, we did not find a statistical significance. The tumor markers were higher in the left colon group compared to the right colon group, and they were not statistically significant. We had a much more important CT lymph node status positive in the left colon cancer compared to the right colon cancer. And the tumor stages were comparable between the two groups. Most tumors were T3 tumors, and T2 tumors also were comparable. We're talking about the TNM classification. the radiological TLM classification. As for T4 tumors, locally advanced tumors, we had a higher rate in the right colon cancer compared to the left colon cancer. And this joins what we said about prognosis, because most of right colon cancers are associated with bad prognosis because they're usually found at a later stage and are usually locally advanced. In the second table, you can see the outcome, the post-operative outcomes and evolution of our patients, meaning also pathology. The stay in the ICU period was comparable with the length of hospital stay longer for right colon cancer. So morbidity-wise, we did not find a lot of differences in the earlier outcomes morbidity-wise, because left colon cancer is also associated with later morbidity. Major complications were more present in the right colon cancer, as we said earlier. As for pathology, we did found that most of our tumors were well differentiated. However, you can see the poorly differentiated ones were only found in our sample in the right colon cancer group. We found none in the left colon cancer group, which could be a factor of bad prognosis as well. The presence of vascular emboli and the involvement of perineural sheath was more present in the right colon group, 22% for the vascular emboli against 3.3%, which was statistically significant. And the perineural sheath was involved in 6% of right colon cancer against 6.5%. We had a higher mortality rate in the right colon cancer, 12 against 8.9%. And as we said earlier, we had a better survival for the left colon cancer group, overall survival, 5-year overall survival, and a comparable disease-free survival. So studying prognostic factors allows clinicians to adapt specific treatments to specific patients and to establish better surveillance protocols. The stage of the tumor progression in colon cancer at the time of diagnosis, it remains the main prognostic factor. However, it is of utmost importance to define all other factors conditioning survival within the same stage. These factors in colon cancer, as we could find in the literature, were clinical, pathological, biological, and genetic. Amongst the prognostic factors frequently studied in literature, we had age, sex, and the presence of complications. So in our series, age did not have a significant impact on overall survival. However, using a multivariate analysis by Cox regression, we were able to establish that age over 61 years was a predictive factor of poor prognosis in recurrence-free survival, with a hazard ratio of 3.245 and a significant P of 0.023. So we did find age as a predictive factor in recurrence-free survival. We could not demonstrate it, that it had an impact in overall survival, but still, this was an interesting finding that rejoins what we found. We also noted, as I said earlier, that the age in our series was significantly younger, and it could be due to environmental factors, as I said earlier. We found no difference and no impact of sex on the outcome of colon cancers. As for major complications, no statistically significant difference in overall survival for both groups was identified. Disease-free survival, though, was better for both groups in the absence of major complications, without it being statistically significant. So in case of the absence of major complications, we did find that there was a better disease-free survival rate. Sorry for the cough. So for tumor stage, as we said, it was the main prognostic factors that we could find in literature, and so it was only logical that we studied as well. So no difference in overall survival was present among patients who underwent surgery for stage 1 and stage 2 in both cancer groups. However, we did find a better overall survival for stage 3 and stage 4 tumors with left colon cancer groups. So if you have a stage 3 and 4 left colon cancer, you have a better chance of overall survival than if you have a stage 3 and stage 4 tumor in the right section of the colon. Survival without recurrence was better in patients with stage 1 and 2 in left colon cancer, yet again, compared to those from the right colon cancer group, and no difference in survival without recurrence was for tumors of stage 3 and stage 4. So we could therefore conclude that for our study, tumor stage was a predictive factor of bad prognosis in colon cancer, in favor, of course, of the left colon cancer, which joins what we found in literature. So tumor stage, locally advanced right colon cancers are associated with a worse and pejorative prognosis. As for involvement, it was lymph node involvement is also a prognostic factor. In literature, we're talking about a fall of the 5-year survival rate from 70% to 11% in case of lymph node involvement. So also, which explains the importance to study this factor. For our patients, overall survival was better for patients who underwent surgery with a lymph node involvement. No difference was found in recurrence-free survival in cases of lymph node involvement. However, in our multivariate analysis using a Cox regression, nodal involvement was retained as a predictive factor for recurrence, with a hazard ratio quite high at 4.5. So this is another predictive factor of bad prognosis that we were able to identify. We found age, we found tumor stage for stage 3 and 4, and this was the third one that we could identify through our study. And it is interesting that we had this statistical response because we join what we found in literature, so which makes our work quite worthy of the trouble. Vascular emboli and perineural invasions are also of pathological importance. The perineural invasion is considered to be a independent risk factor for local regional recurrence in colon cancer. Some studies did not report any difference between the right colon cancer groups and left colon cancer groups regarding the presence of perineural invasion, and others reported a higher rate in patients with right-sided colon. For us, for our study, we did not find a significant difference in overall survival in the presence of vascular emboli or a perineural invasion, although we found them more present in the right colon cancer group, as we said in the summary table earlier. No impact on recurrence-free survival also, and no difference was observed with the P of 0.4 and 0.48. So as every study, we have to acknowledge a few limits that we had. So one of them I've talked about earlier, and it's the lack of complete follow-up data for more than 35% of the patients that we include in our sample. And that could, to some extent, impact the results that we found. Our study also has analyzed a decent number of patients, so even the slightly different results between right and left colon cancer turned out to be statistically significant. So while they should be taken into consideration, their clinical significance should nonetheless be carefully evaluated. And we would do better if we could continue this study through the years, so we could make our sample a little bit bigger and our selection process a little more precise. And we arrive at the conclusion then. As you can see, colon cancer, they come from different origins. We did not speak a lot about the molecular patterns, but they have also molecular differences. Right colon cancers are associated with a lot of mismatch repair genes, KRAS, BRAF, and the left colon cancer is associated with the P53 genes and NRAS and CIN genes. So embryologically, anatomically, and on the molecular level, they are quite different. And as you can see, even this difference has an impact on the outcome. So to this day, they're still treated as a single disease, despite the numerous studies highlighting the differences. And our research has confirmed variations in the epidemiological factors, complications, and overall survival. We also demonstrated in particular that right colon cancer is associated with a poorer prognosis, and that age, tumoral stage, nodal involvement are predictive factors of bad prognosis. The findings suggest that colon cancers should be separated into distinct diseases, given that left and right colons are from different origins, as I said, follow different disease courses, exhibit distinct molecular patterns, and resulting in dissimilar prognosis. Therefore, identifying and treating left and colon cancers as separate entities, separate diseases, could lead to a more targeted and effective treatments, resulting in a better patient outcomes. Thank you. That was all for me.
Thank you so much, Dr. Mehdi Idrisi. It was a great talk. I learned a lot from you, and this information for me as pathologist is quite informative, and it's always good to hear from the surgeons as well. And as we work so closely and in a close collaboration, so a very, very thorough study and a very good information provided. I just wanted to ask, maybe I missed in your talk, but what was the sample size? How many patients did you include in your study?
We started off with 350 patients at first, but we had some missing files, and we applied some exclusion criteria. We found patients who had double locations of the tumors, so we excluded those. We found patients with colons, we excluded those. So we ended up with 277 patients divided into two groups. Right colon cancer with 100 and 177 for the left colon cancer group.
Okay. And it was just in one organization in the hospital?
Yes, just one. Yes, just one hospital, okay. The University Hospital. Yeah.
Perfect. Great. Thank you so much. Any questions from the audience? Let me check the chat box to see if there are any questions. Amazing. Great. Thank you so much once again, Dr. Idrisi. So the two speakers that were supposed to come today due to the emergency and unforeseen circumstances, they're not able to present to us. So they've contacted the organizers, and they will provide their recorded sessions to the organizers, which will be emailed to all the attendees and the speakers. So with this, we will conclude our conference. Thank you so much, everyone, for coming together, and we learned a lot. And apologies for all the technical issues, not under my control. It's so maybe we can provide some feedback as well. In terms of the conference certificate to the speakers and to all the attendees, they will be provided by the organizers. So please do check your email, and they'll start distributing that from tomorrow. With that, I will conclude the meeting. It was so nice meeting everyone who was here in person in Berlin. I had a great time, and talking to everyone today, and knowing and seeing the horizon of digital pathology, how it is in different parts of the world. So I really appreciate and thank you each and everyone for their contribution and for making this conference a worthy one. Thank you. Any questions?